السلام الملكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين، نبينا وحبيبنا وقدوتنا محمد عليه وعلى آله أفضل صلاة وأتم تسليم. ثم أما بعد، أصحاب السعادة، السادة الحضور، مشاهدين الأعزاء، السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم وجميع أوقاتكم بكل خير وبركة وسرور. ومرحبا بكم في المؤتمر الأول للبرنامج الوطني للاضطرابات النمائية والسلوكية، والمقام في الفترة من 13 نوفمبر إلى 15 نوفمبر لعام 2022 تحت رعاية سعادة وكيل الوزارة للخدمات العلاجية الدكتور طريف بن يوسف الأعمى، والذي يهدف هذا المؤتمر إلى تحديد التحديات التي تواجه مقدمي خدمات علاج اضطرابات النمو والسلوك. وخير ما نبدأ به آيات من الذكر الحكيم.
ألم تر أن الله أنزل من السماء ماء فأخرجنا به ثمرات مختلفا ألوانها ومن الجبال جدد بيض وحمر مختلف ألوانها وغرابيب سود ومن الناس والدواب والأنعام مختلف ألوانه كذلك إنما يخشى الله من عباده العلماء إن الله عزيز غفور.
صدق الله العظيم. كلمة الافتتاح يتفضل الدكتور عبد الله بن محمد السهيمي، مدير عام شؤون المراكز المتخصصة بوزارة الصحة.
الحمد لله، والصلاة والسلام على رسول الله محمد بن عبد الله وعلى آله وصحبه ومن والاه، وعنا معهم برحمتك يا أرحم الراحمين. وبعد، سعادة الوكيل المساعد لخدمات المستشفيات بوزارة الصحة، أصحاب السعادة، ضيوفنا الكرام، زملائنا الأعزاء، أيها الحفل الكريم، السلام عليكم ورحمة الله وبركاته. وبعد، نرحب بكم جميعا في هذا الصباح الجميل، وعلى دروب الخير والعطاء نلتقي، وبالخبرة والعلم والعمل نرتقي. برنامج نمو كان فكرة، ثم تحول إلى حقيقة، ثم إلى عطاء مستمر. ابتدأ البرنامج الوطني لاضطرابات النمو والسلوك بمسمى نمو ببضع عيادات متفرقة، وها هو اليوم ينتشر في كل أنحاء المملكة بأكثر من 100 عيادة للتشخيص المبكر، و14 عيادة متخصصة، و13 مركزاً متخصصاً، وذلك لتقديم خدمات تشخيصية وبرامج تدخل مبكر. وما زال التواصل مع جميع شركاء النجاح لتجويد الخدمات وتطويرها، وذلك بمد جسور التعاون مع الجمعيات المتخصصة والمراكز الحكومية والخاصة، حتى نصل إلى الهدف المنشود، ونحقق جميعاً رؤية المملكة العربية السعودية 2030 في تطوير منظومة الخدمات الصحية عن طريق تحقيق الأهداف المستدامة والأهداف الاستراتيجية لبرنامج التحول الوطني بملف وزارة الصحة، بتسهيل الحصول على الخدمات الصحية ورفع الجودة والكفاءة. وهذا المؤتمر هو أحد الأدوات التي تسهم في ذلك، فحضوركم اليوم زادنا تشريفا وبهجة، ووضع على عاتقنا جميعا مسؤولية العمل الدؤوب لتطوير البرنامج لاضطرابات النمو والسلوك، والخروج بتوصيات وخطط عمل منهجية ومتابعة وتوجيه من دعم وقادتنا بوزارة الصحة. فحياكم الله جميعا، والسلام عليكم ورحمة الله وبركاته.
شكرا للدكتور عبد الله بن محمد السهيمي، مدير عام شؤون المراكز المتخصصة بوزارة الصحة، على هذه الكلمة. والآن نترككم مع كلمة المدير العام للمركز الوطني لاضطرابات النمو الشامل بالمجلس الصحي السعودي، الدكتور أحمد بن محمد أبو عباه، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. صباح الخير عليكم جميعا، الأخوة الزملاء، الأخوات الزميلات، الحضور الكرام. سعيد جدا أن ألقي نيابة عن الشركاء في هذا المؤتمر الأول. الحقيقة قبل دخولي للمؤتمر سمعت عن يمكن رقم لأول مرة أسمع أنه عدد المسجلين في هذا المؤتمر فاق عدد كبير جدا، ويمكن اضطر الزملاء إلى أن يوقفوا التسجيل مؤقتا ثم يعاودوا التسجيل. فهذا أعطاني مسؤولية كبيرة أني أتحدث نيابة عن الشركاء، نيابة عن الحضور، عن هذا الحدث الكبير، واللي الحقيقة يعكس أننا متعطشين لمثل هذه النوعية من المؤتمرات على هذا المستوى وبهذه الجودة والتنوع كذلك. فإذا سمحوا لي الزملاء سأحاول أن أقدم بعض الأمور اللي أرى أنها تكون ضرورية في بداية مثل هذه المؤتمرات، وأحتاج العرض إذا تكرمتم. نحن في المجلس الصحي السعودي الحقيقة نعمل في 3 محاور. نحن لسنا مزودي خدمة، لكننا نعمل على وضع التشريعات اللازمة في القطاعات الصحية فيما يخص الاضطرابات النمائية السلوكية، ونعمل على التكامل والتنسيق بين الجهات من أجل الحصول على جودة خدمة، وكذلك على توزيع جغرافي يكون راضي للجميع. طبعا الجميع يعرف عن رحلة الطفل التوحدي، وأنها تبدأ إما من قلق لدى الأسرة من سلوك طفل معين، وهذه نقطة الحقيقة جدا مهمة، ويمكن حتى كذلك تفتقر إلى بعض الأبحاث أنه هل فعلا الأسر ممكن أن يكون لديها قلق من سلوك أطفالها أم لا. وبالتالي صدرت السياسة الوطنية للمسح الوطني المبكر لاضطراب طيف التوحد بشكل خاص، وهذا الفحص المبكر أصبح الآن بعد الموافقة السامية أصبح وضع إلزامي، سأتحدث عنها بشكل إن شاء الله أكثر تفصيلا. بعدها يأتي على موضوع التشخيص، ومثل ما ذكر سعادة الدكتور عبد الله أن أصبح الآن في عدد الحقيقة كبير من المراكز سواء التابعة لوزارة الصحة أو للقطاعات الصحية الأخرى أو حتى للقطاع الخاص تقدم هذا التشخيص اللي يعقبه مباشرة التسجيل في السجل الوطني للتوحد. كذلك يأتي بعد ذلك التدخل المبكر، يليها الدمج المدرسي، ومن ثم التدريب المهني والوظيفي لمن لديهم القدرة. هذه الرحلة الكبيرة لعلنا اليوم بمشيئة الله في إحدى ورش العمل سنناقش الفجوات في هذه الرحلة، ونحتاج منكم الحضور في هذه الورشة ومشاركتنا طرح هذه التحديات في هذه الرحلة الطويلة التي الحقيقة ليست سهلة، لا سواء على مقدمي الخدمة ولا على المستفيدين من الأسر. يمكن لو نعم. السياسة الوطنية للكشف المبكر لاضطراب طيف التوحد هي إحدى السياسات الوطنية اللي تم إصدارها من المجلس الصحي السعودي، وهي أقرت تقريبا في بداية عام 1442 من المجلس الصحي السعودي، ومن ثم تم رفعها إلى المقام السامي، واعتمدت من المقام السامي كسياسة وطنية للمسح المبكر لاضطراب طيف التوحد تقريبا في بدايات عام 1443. هذه السياسة الوطنية تلزم القطاعات ذات الصلة، يمكن في الشريحة اللي بعدها. هذه السياسة تنطبق على جميع مراكز الرعاية الصحية الأولية، وكذلك على جميع العيادات التي فيها عيادات لطب الأسرة والمجتمع. السياسة تتكون من عدة مكونات. أولاً إجراء خدمات الكشف المبكر عن طريق الأداة المعروفة اللي هي الإمشات، وكذلك يجب أن تتم خلال الفترة الزمنية ما بين 15 إلى 24 شهر. يتطلب من الجهات الصحية بشكل عام تشكيل فرق بقطاعاتها بطريقتها لإدارة هذا التنظيم وتوثيقه، وكذلك تدريب وإرسال النتائج إلكترونياً. كما ذكرت لكم، هذه السياسة تطبق على جميع مراكز الرعاية الصحية الأولية أو عيادات طب الأسرة والمجتمع، وبالتالي نتوقع أنه عندما يكون الطفل في زيارة إلى مراكز الرعاية الصحية وبدون ما يطلب من هذه المراكز إجراء الكشف، لأنه كما ذكرت لكم قد يكون هناك مشكلة أو ما تلاحظ الأسرة بعض السلوكيات، وبالتالي إجراء هذا المسح مبكراً عند حضور الطفل سواء لعيادات الطفل السليم أو لأخذ اللقاحات اللازمة يتم تطبيق هذا الكشف المبكر عليهم. كذلك من مكونات السياسة أنه عندما يكون هناك اشتباه هنا من وجود أي نوع أو أي طيف من طيف التوحد، أنه يجب إحالة الحالات التي يكون لديها عامل خطورة كبير إلى العيادات التخصصية لإجراء الكشف المبكر، ومن ثم يتم التأكيد من خلال التقييم الكلينيكي. ومن ضمن السياسة ضرورة عمل فحص السمع. تسجل جميع الحالات التي تم تأكيدها في السجل الوطني لاضطراب طيف التوحد، والذي الحقيقة تم إقراره مؤخراً وسيكون قريباً موجود على المنصة بمشيئة الله، ويمكن جميع الجهات الصحية للدخول لهذا السجل وتسجيل الحالات الجديدة. لا شك أن هذه السجلات سوف تعطي متخذ القرار من معرفة كثير من المعطيات اللي تساعدهم في بناء الاستراتيجيات، وكذلك في إجراء البحوث وإعطاء الأولويات لمقدمي الخدمة حسب كل قطاع فيما يخصه. لا شك أنه بما أنه هذه السياسة مقررة من المقام السامي، فتم وضع مؤشر خاص لمتابعة مدى التزام القطاعات الصحية بهذه السياسة، ومطلوب مننا من المجلس الصحي السعودي الرفع بتقارير دورية لمعالي رئيس المجلس وكذلك إلى المقام السامي. السجل الوطني لاضطراب طيف التوحد يتكون من 3 الحقيقة جزئيات. يمكن احنا الآن بدأنا في الجزئية الثانية، وهي تسجيل الحالات بعد التشخيص المبكر مباشرة، وهي السياسة أو السجل الذي سوف يصدر. لكن هناك جزئية أولى بمشيئة الله سيكون الكشف المبكر كذلك موجود على المنصة، ولكن هذا قد يأخذ بعض الوقت. كذلك للحالات التي شخصت سابقا سيكون لها آلية في تسجيلها في السجل الوطني للتوحد، لكن سيتعطى الأولوية الآن للحالات الجديدة التي يتم اكتشافها من بداية عام 2022. السجل الوطني لاضطراب طيف التوحد مكون الحقيقة من عدة مكونات، في معلومات ديموغرافية عن الطفل والأسرة، كذلك عن التاريخ الطبي، ومعلومات عن التشخيص والتقييم الإكلينيكي والعلاج الطبي والتأهيلي. هذه المعلومات هي لا تغني عن التقييم الإكلينيكي المفصل، وبالتالي هي معلومات تساعد متخذ القرار في وضع الاستراتيجيات، في وضع السياسات، وكذلك مزود الخدمة يستفيدون منها من توزيع الجغرافي للعيادات والخدمات التي يعاني كثير منها من المستفيدين من التحدي في التوزيع الجغرافي. من ضمن الحقيقة مبادراتنا في الكشف المبكر لاضطراب طيف التوحد هو إعطاء المستفيدين القدرة على إجراء الكشف لوحدهم حتى بدون زيارة مراكز الرعاية الصحية الأولية من خلال تطبيق نمائي، وهذا التطبيق الآن موجود على المتاجر الإلكترونية ومتاح للجميع. بعد التسجيل الحقيقة لا يأخذ سوى دقيقتين لاكتشاف هل الطفل لديه اشتباه في طيف التوحد أو لا. بمشيئة الله سيكون قريبا الدخول عن طريق النفاذ الوطني، وبالتالي يعطي هذا التطبيق أو هذا الإجراء أو هذه المبادرة تعطي إلى مصداقية كثيرة، وكذلك نستطيع الاستفادة من المعلومات الوطنية الموجودة لدى الطفل أو الأسرة. أعتذر يمكن الريموت ما يصل مباشرة، لأن المفترض أن احنا نروح للأمام. طبعا هذا هو تطبيق، من أراد أن يقوم بتحميله وموجود، مجرد أنك تكتب نمائي سيكون التطبيق أمامكم. بعد التشخيص سيعطينا 3 فئات كذلك مميزة بالألوان، اللون الأحمر واللون الأصفر واللون الأخضر، حتى يعطي العائلة مؤشر لمدى مستوى الخطورة. كذلك نحن لدينا في المركز الوطني لاضطرابات النمو الشامل في المجلس الصحي السعودي لدينا قاعدة بيانات لتصنيف المراكز المقدمة للخدمات، سواء مراكز الكشف المبكر وهي مراكز الرعاية الصحية الأولية التابعة لجميع القطاعات الصحية، وكذلك العيادات التخصصية التي تقوم بالتشخيص، وكذلك مراكز التدخل المبكر بغض النظر عن تبعيتها، سواء التابعة للقطاعات الصحية أو التابعة للقطاعات التعليمية أو الاجتماعية. ومن أراد الحقيقة الاستفادة من هذه قاعدة البيانات يستطيع الحصول عليها من خلال الدخول لموقع المجلس الصحي السعودي. وهذه دعوة للجميع للجهات اللي ما كانت مسجلة عندنا بالإمكان التواصل معنا عن طريق هذا الإيميل لتسجيل هذه المراكز. الميزة عندما يكون مسجلين المستفيدين يستطيعون يعرفون أين يذهبون، لو عنده طفل عنده اشتباه أين يذهب، لو كان هو أخذ التطبيق الآن وعرف أن عنده اشتباه يستطيع الحصول على معلومات عن العيادات، ومن خلال أهليته للعلاج يتوجه للعيادة المناسبة. كذلك مراكز التدخل المبكر، أرجو من الجميع اللي لديه يعني رغبة في الدخول معنا فأهلا وسهلا، وبإمكانهم التواصل معنا. من ضمن الحقيقة خدماتنا كذلك هو صدور دليل الإجراءات الكلينيكية لاضطراب طيف التوحد، اللي بحمد الله الأسبوع الماضي تم اعتماده من المركز الوطني للطب المبني على البراهين، وأصبح الآن هو مرجع وطني للممارسات الكلينيكية في اضطراب طيف التوحد. بمشيئة الله نظرا لصدور الاعتماد الأسبوع الماضي ويوم الأربعاء ما تمكنا من إرساله للجميع، لكن سوف يكون متاح على الموقع، وسوف يتم إرساله كذلك لجميع المسجلين لدينا في قاعدة البيانات. الحقيقة اللي قام عليها لجنة علمية منبثقة من اللجنة العلمية للمركز الوطني لاضطراب طيف التوحد، واللي رأسها معنا سعادة أخي سعادة الدكتور صالح الصالحي، مشكورين. دليل وطني مرجعي يعتبر هو المرجع الأساسي في الممارسة الإكلينيكية في هذا المجال. كذلك نعمل حاليا على وضع الدليل الوطني للتدخل المبكر لاضطراب طيف التوحد والاضطرابات النمائية المشابهة. نتوقع بمشيئة الله في قبل نهاية عام 2023 يكون هذا الدليل مرجعي وكذلك معتمد من المركز الوطني للطب المبني على البراهين، وسيكون بالإضافة إلى الدليل الوطني للممارسة الكلينيكية وكذلك التدخل المبكر مرجعين هامين لجميع ممارسين في المراكز المقدمة للخدمات لذوي الاضطرابات النمائية. كذلك من المشاريع اللي قمنا فيها، وهذه دعوة للجميع، الآن قرب صدور معايير سباهي لمراكز التوحد. نتوقع إن شاء الله خلال أسبوعين أو 3 يتم الإعلان، وبالتالي من رغب في الدخول في الاعتماد يستطيع أن يتواصل مع المركز السعودي لاعتماد المنشآت الصحية سباهي والحصول على هذه الشهادة. لا شك أنه قد تكون في بدايتها اختيارية، ولكن نتوقع أن تكون إلزامية في القريب العاجل. لذلك هي دعوة للجميع للتواصل مع المركز السعودي لاعتماد المنشآت الصحية والحصول على هذه المعايير، والبدء من الآن في التحضير لأخذ الاعتماد. نتوقع كذلك أن يدخل في الاعتماد المراكز التي تقدم الخدمة والتي ليست تابعة للقطاعات الصحية كذلك. من ضمن المشاريع اللي نعمل عليها هو وضع مشروع تقويم وطني للنشاطات العلمية في مجالات اضطراب طيف التوحد. نحن لدينا نية في المجلس الصحي السعودي لعقد مؤتمر هذا العام، ولكن تم تأجيله نظرا للعدد الكبير من النشاطات المتاحة. فوجدنا أنه هناك أحيانا في الأسبوع الواحد يكون في أكثر من نشاط، يكون في أكثر من مؤتمر تابع لعدد من القطاعات. مقدمي الخدمة للاضطرابات النمائية متعددة سواء صحية أو تعليمية أو اجتماعية. فارتأينا في المجلس الصحي السعودي نخاطب الجميع: أعطونا نشاطاتكم وخلونا نحطها في تقويم سنوي الجميع يستفيد منها، حتى الجهة اللي تبغى تعقد مؤتمر أو تبي تضع أي نشاط علمي بالإمكان الحصول على الموعد أو يختارون المواعيد المناسبة. للأسف هناك أسابيع تتركز فيها هذه الخدمات. وجدنا مؤخرا أكثر من 90 نشاط تتركز خلال 2 فقط. فتوقعوا لو وزعنا الشهرين أو 90 نشاط في شهرين حيكون في زحمة كبيرة، وبالتالي يفوت الفرصة. وبالنسبة لي يعني جودة الخدمة أو جودة التعليم اللي سيكون هنا قد ما تكون الحقيقة بالشكل المطلوب، لأنه وجدنا ناس ممكن أن يخرج من مؤتمر وهو محاضر ليذهب إلى مؤتمر آخر يقدم تقريبا نفس العرض ولكن في موقع آخر. وبالتالي هذه دعوة للجميع رجاء. تم مخاطبة من لدينا يعني معلوماتهم أو عناوينهم، لكن اللي يعني ما سجل أو ما قدم معلوماته هي دعوة للجميع، هي ليست إجبارية، ولن نتدخل في موضوع أن تقيم أم لا، ولكن نريد أن نحصرها بما أننا إحنا منسقين وندعو للتكامل. فأعتقد أن هذه إحدى أساليب التكامل، وبالتالي نستطيع الاستفادة من هذه النشاطات. الحقيقة من ضمن المشاريع اللي نعمل عليها، ودائما أطباء الأطفال، الأطباء النفسيين، أطباء الأعصاب الذين يقومون بتشخيص الأطفال التوحديين أكبر هم عنده ماذا أعمل إذا تم التشخيص. الآن إحنا لدينا السجل الوطني للتوحد. من خلال هذا السجل الوطني للتوحد سنعرف كل حالة تم تشخيصها. الآن نعمل على مشروع إن شاء الله نتمنى أن يرى النور قبل نهاية عام 2023، وهو مشروع الإحالة، مكون من جزئين. الجزء الأول بعد الكشف المبكر، عندما يكتشف الشخص أنه عنده اشتباه عنده طفلة، أين يذهب؟ هناك أهليات علاج كبيرة. احنا نعرف في أنظمة اللي تابع لقطاع معين قد ما يكون له أهلية في القطاع الثاني. الآن مع التجمعات قد يكون له أهلية معينة في موقع آخر. إن شاء الله سيتم عقد ورشة عمل مع جميع الشركاء لوضع الآلية المناسبة للإحالة. النقطة الثانية هو بعد التشخيص، عندما يتم تشخيصه أين سيذهب؟ احنا نعرف انه هناك مراكز للتدخل المبكر مثل ما ذكر الدكتور عبد الله، تابعه للقطاعات الصحيه، في تابعه للقطاعات التعليميه او كذلك للقطاعات الاجتماعيه، وهناك الحقيقه آلية وهناك شروط. على سبيل المثال في وزاره التعليم يقبلون من عمره 3 سنوات فما فوق. مع السياسه الوطنيه للكشف المبكر ممكن ان نكتشف ناس في اعمار اقل، اين سيذهبون الان؟ وبالتالي أصبح لدينا مهمة كبيرة في القطاع الصحي. عندما يتم تشخيص الطفل يجب أن نضمن بدل ما يذهب ويبحث عن مركز لقبوله، نحاول أن نساعده في الحصول على أقرب موقع جغرافي، وهذه جدا مهمة لأنه التدخل المبكر يحتاج إلى فترة زمنية طويلة ويحتاج إلى جهد، والأسرة قد تجد صعوبة في الانتقال إلى مدينة أخرى للحصول على التدخل المبكر اللازم. فبمشيئة الله سيكون هنا هذا المشروع بالتعاون مع عدد من الشركاء. معنا الشريك الأساسي هي جمعية أسرة توحد، مشكورين. سيكون هذا المشروع بمشيئة الله يرى النور قبل عام 2000 ونهاية عام 2023. الحقيقة أنا كانت هذه رغبتي في تقديم صورة كبيرة. مثل ما ذكرت لكم احنا لسنا مزودي خدمة، ولكن نحن مشرعين ننسق، ندعو للتكامل مع الجميع، وهذا دورنا في المركز الوطني لاضطرابات النمو الشامل. شكرا جزيلا للزملاء في المؤتمر لإعطانا هذه الفرصة للمشاركة من هذا المركز الوطني. بمشيئة الله نكون مساعدين وداعمين لهذه الجهود. أكرر من لديه الرغبة في التواصل معنا عن طريق الإيميل فأهلا وسهلا بكم، وشكرا جزيلا.
شكرا للدكتور أحمد بن محمد أبو عباه، المدير العام للمركز الوطني لاضطرابات النمو الشامل بالمجلس الصحي السعودي. والآن نترككم مع كلمة راعي الحفل، وكيل الوزارة للخدمات العلاجية الدكتور طريف بن يوسف الأعمى، ويلقيها نيابة عن سعادة وكيل الوزارة المساعد لخدمات المستشفيات الدكتور فيصل بن سالم الدهمشي، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. الزملاء والزميلات الكرام، أصحاب السعادة، الحفل الكريم، المحاضرين، المحاضرات، لجان التنظيم، السلام عليكم ورحمة الله وبركاته. يسرني اليوم أن أرحب بكم جميعا في الملتقى الأول للاضطرابات النمائية من تنظيم أبطال الإدارة العامة للمراكز المتخصصة، وبالتكامل مع جميع القطاعات المقدمة لخدمات اضطرابات النمو والسلوك. أنا ما أبغى أطيل اليوم، سعيد جدا أن يكون موجود معاكم، ولكن لي 3 رسائل إن شاء الله تكون سريعة ومباشرة. الرسالة الأولى رسالة شكر من راعي هذا الحفل، سعادة الوكيل للخدمات العلاجية الدكتور طريف بن يوسف الأعمى، يقدم لكم شكره ويتمنى أنه كان موجود معكم اليوم لظرف وجوده خارج منطقة الرياض، فشكرا لكم جميعا باسم راعي هذا الحفل. الرسالة الثانية رسالة للجان المنظمة والعاملين على هذا الملتقى الرائع. هنيئا لكم بوادر نجاح هذا الملتقى. أنا قاعد أسأل أخوي الدكتور عبد الله قبل لا أبدأ كم الحضور، أحس العدد اللي أعطاني إياه أقل من اللي قاعد أشوفه قدامي، فشكرا لكم من الأعماق. أنا جدا سعيد أني أشوف مثل هذا الملتقى في دقائقه الأولى وصل الحضور أكثر من 700 حضورا و700 في اللايف، والعدد اللي وصلني في الأونلاين عدد كبير جدا، يمكن لا أستطيع حتى التصريح فيه لحين ما يتأكدون زملائنا. هذه إشارة أنه الناس متعطشة لتقديم الخدمات. وصلنا مرحلة من الإحسان والإتقان إلى أنه الجميع يحضر في الدقائق الأولى مثل هذا العدد الكبير، فالحمل زاد، الإكسبكتيشن والتوقعات ارتفعت. فأسأل الله العلي العظيم أن يبارك بجهودكم جميعا، وأن ينفع في كل ما تقولون وتعملون في هذا الملتقى الرائع. الرسالة الثالثة، أؤكد على اهتمام وتركيز ودعم وزارة الصحة في هذه الخدمات الهامة جدا والحساسة لهذه الفئة الغالية علينا جميعا. باسم الإدارة العامة لشؤون المراكز المتخصصة بالخدمات العلاجية، أنا متأكد أن كل ما سيذكر اليوم من توصيات ستؤخذ بالحسبان ويكون لها بإذن الله آذان صاغية. ولكن أتمنى اليوم ودنا نركز أن التوصيات تكون جدا واضحة لمقدم الخدمة. الآن مقدم الخدمة في عندنا انتقال، في عندنا شركة الصحة القابضة، فالخدمة الصحية اللي أنا أتكلم عنها اليوم أذرعت الوزارة التشغيلية لها شركة الصحة القابضة، واللي يوافق المقام السامي على تأسيسها. فأتمنى من الجميع المحاضرين والحضور أن يكون تركيزنا اليوم ما هي التوصيات لمقدم الخدمة. مقدم الخدمة يتوقع منكم توصيات داعمة لتقديم الخدمة، كيف يبدع، كيف يحسن في تقديم خدمات رعاية أطفالنا من لديهم اضطرابات نمائية. رسالتي الثانية رسالة منظم الخدمة الصحية اللي هي وزارة الصحة. الآن أتمنى فعلا من توصياتكم أن نخرج، لو كنت مكان الشخص المنظم للخدمة الصحية، ما هي توصياتك؟ كيف يستطيع من توصيات هذا اليوم أن يأخذها بالحسبان ويطور نظام الإشراف والمتابعة والرقابة على الخدمة الصحية لأطفالنا من لديهم اضطرابات نمائية. رسالتي الثالثة أيضا، ما هي توصياتك ومقترحاتك المجلس الصحي السعودي، واللي الآن سينظر إلى جميع المقدمين الصحيين والتعليميين وغيرهم من يهتم في خدمات رعاية أطفالنا من ذوي الاضطرابات النمائية والسلوكية. فأتمنى أن نخرج بتوصيات نعدكم أن ندرسها بدقة متناهية، سنعمل جميعا على تنفيذها، وإذا التقينا في النسخة الثانية تكون حققت، ونهدف إلى توصيات أخرى ومقترحات أخرى وأحلام أخرى نتمنى أن نحققها في النسخة الثانية. شكرا لكم من الأعماق. أسأل الله العلي العظيم أن يبارك في هذا الحفل الكريم، وأن يجعل كل ما تقولونه وتفعلونه في خدمة أطفالنا في ميزان حسناتكم، ونلتقيكم إن شاء الله دائما على عز وخير ومعزة، ونشوفكم على خير بإذن الله.
الشكر أيضا موصول لك دكتور فيصل على هذه الكلمة. والآن يتقدم الدكتور رائد بن فهد مطيري مساعد المدير العام لشؤون المراكز المتخصصة بوزارة الصحة لتكريم شركاء النجاح.
السلام عليكم ورحمة الله وبركاته. شكرا لحضوركم المؤتمر الأول للبرنامج الوطني للاضطرابات النمائية والسلوكية. انطلاقا من قول الرسول صلى الله عليه وسلم: من لا يشكر الناس لا يشكر الله. من هذا المنطلق شكرا كثيرا لشركاء النجاح الذين وضعوا بصمتهم في مجال الاضطرابات النمائية والسلوكية. نبدأ بتكريمهم على جهودهم المتميزة. مركز جودة الحياة يمثلهم الدكتور عبد المحسن بن سعد العتيبي. تفضل سعادة الوكيل المساعد خدمات المستشفيات الدكتور فيصل بن سالم الدهمشي، وسعادة مدير عام الشؤون المراكز المتخصصة الدكتور عبد الله السهيمي لتكريمهم على جهودهم المتميزة. مدير عام المركز الوطني لاضطرابات النمو الشامل بالمجلس الصحي السعودي الدكتور أحمد أبو عبا. قائد تخصص اضطرابات النمو والسلوك بوزارة الصحة الدكتور عبد الهادي بن عتيق الهباد. مدير البرنامج الوطني للاضطرابات النمو والسلوك بوزارة الصحة الأخصائية فاطمة محمد الكشر. نبدأ الآن مع تكريم المراكز المتميزة في تخصص اضطرابات النمو والسلوك في وزارة الصحة. بداية مركز اضطرابات النمو والسلوك بمستشفى الولادة والأطفال بالدمام. مركز اضطرابات النمو والسلوك بمدينة الملك فهد الطبية بالرياض. مركز اضطرابات النمو والسلوك بمستشفى شرق جدة. عيادة اضطرابات النمو والسلوك بمستشفى الملك عبد العزيز التخصصي بالجوف. عيادة اضطرابات النمو والسلوك بمستشفى الصحة النفسية بالأحساء. عيادة اضطرابات النمو والسلوك بمستشفى الولادة والأطفال بالأحساء. مركز اضطرابات النمو والسلوك بمستشفى الولادة والأطفال بمنطقة نجران. الآن مع تكريم أعلى 5 أطباء تسجيلاً في سجل رصد الحالات، الدكتور علي إسماعيل عبد الرحمن. الدكتورة فاطمة عبد اللطيف. الدكتور إيهاب علي. الدكتورة أميرة حمد صميلي. الدكتور نبهان بن عبد الله. الآن مع تكريم المنسقين المتميزين في مراكز وعيادات اضطرابات النمو والسلوك، الأستاذة خلود العنزي، الأستاذة لولو عيد البخيت، الأستاذ حسن أحمد الشريف، الأستاذة جميلة ناجي القحطاني، الأستاذ فهد محمد الغامدي، الآن يتفضل سعادة الدكتور عبد الله بن محمد السهيمي مدير عام شؤون المراكز المتخصصة بتكريم راعي الحفل الدكتور طريف بن يوسف الأعمى وكيل الوزارة للخدمات العلاجية، ينوب عنه سعادة الدكتور فيصل بن سالم الدهمشي وكيل الوزارة المساعد لخدمات المستشفيات. الآن يتفضل الدكتور تفضل راعي الحفل الكريم الدكتور فيصل بن سالم الدهمشي الوكيل المساعد بتقديم درع تذكاري وتكريم للإدارة العامة لشؤون المراكز المتخصصة. الآن مع تكريم الأستاذ عاطو شلبي مدير عام شركة الخيول الثلاثة على جهودهم في تنظيم هذا المؤتمر.
والآن صورة تذكارية مع سعادة راعي الحفل. وبعد هذه الصورة التذكارية وشكر من يستحقون الشكر، ننطلق نحن وإياكم لافتتاح المعرض المصاحب، وبعدها نعود بإذن الله إلى ورش العمل. وتقبلوا تحيات محدثكم ناصر الحربي، والسلام عليكم ورحمة الله وبركاته. نستأذنكم الآن بإذن الله، ستبدأ المحاضرات ويتزامن أيضا مع افتتاح المعرض، فنستأذنكم بالجلوس.
السلام عليكم ورحمة الله وبركاته. حيبدأ البرنامج العلمي الآن، يعني لأن تأخرنا تقريبا حول أكثر من نص ساعة، المتحدث من خارج المملكة، فأتمنى من الجميع أنهم يعني ينتظرون. هلا هلا هلا. الناس جاهزة هي؟ سلام. اوكي. اوكي، بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Good morning everyone. we'll start a scientific program. We are late, as I mentioned earlier. Our first speaker will be on virtual from the United States of America. بس please before we start قبل ما نبدأ الرجاء أن الجميع يحط الجوال على الصامت حتى ما يكون فيه تقاطع، فبنعطيكم 5 ثواني كل واحد يحط الجوال على الصامت، نوقف كذا. اوكي دن. ثانيا قبل ما نبدأ، يعني أنا اليوم سعيد لأن أشوف برامج تكرم. مركز نمو الطفل مدينة الكفاءة الطبية بدأناه عام 2004 2003، والآن الشرقية في 1 يناير 2015، والآن ما شاء الله مرجع. فالأمور ماشية بشكل جيد إن شاء الله لخدمة الفئة المصابة باضطرابات النمو. فأسأل الله سبحانه وتعالى التوفيق للجميع بإذن الله. So today our first speaker is Dr. Tuba Rashid Khan. She's the medical director of the developmental neurology program and the pediatric neurology disability specialist at Children's Healthcare of Atlanta Emory University. She completed her medical training at the University of Texas Southwestern Medical Center. She received Master of Public Health degree as well as Master of Education degree from Harvard University. She has been recognized nationally and internationally for advocacy, teaching, and leadership by the American Academy of Pediatrics, being awarded the A.B. Baker Teaching Recognition Award and Future in Neurology Research and other awards. Very distinguished speaker. She will have 55 minutes as per the program to present Autism Spectrum Disorder Assessment and Intervention. Dr. Tuba, the floor is yours now. After the talk, we will give 5 minutes for questions before we end the transmission from the United States. So I know we thank you. We know it's around 1 a.m. at your side. So thank you very much for being with us here. And the floor is yours.
And how is this going to happen? Will I be seeing the presentation or do I just say next? Oh, perfect. Okay, I love it. I can see it now. Okay, this is great. Let me just do this. Okay. And then we'll go from here. Okay. So, as you all know, I'm Dr. Rashid Khan. I'm the Medical Director of the Developmental Neurology Program. And as part of Emory University, we are closely affiliated to the Center for Disease Control, so the CDC as well. So a lot of our policies for children with autism is kind of shared with the CDC as well. And today, I'm going to really talk about autism evaluation and management. We have a wonderful audience with us today. I'm able to see your faces. And so at times I'm going to ask questions and I'm going to give you 10 to 20 seconds to really ponder on what it means to have autism in this day and age. Okay, next. Okay, so the ASD prevalence in the US is 1 in 59 children. Around 10 years ago, is it that there are more environmental factors, there's an increased medical need, the population is increasing, and I really think it's multifactorial, a triad of the reasons why we're seeing an increase in numbers. The standard screening for autism spectrum spectrum disorder is around 18 and 24 months. So we really know in the last 5 years that you can diagnose autism as early as 9 months. A 6-month-old child could be sitting, could be laughing at mom's silly faces. 2-month-old could be chewing and tapping across midline. And so children that are averting eye contact, really aren't engaging with play, you can see those signs as early as those months. And the direct and indirect costs of caring for children back in 2015 were estimated to be $268 billion, more than the cost of stroke and hypertension. So I'm going to pose a question and I'm going to give you 5 seconds to really guess a number. I want you to guess what the number in terms of US dollars is for stroke. It's around 100-something billion dollars, so less than half. So that is the importance of autism and really dealing with it and supporting our society. Because the cost is worse if we don't deal with this and support our children and their families. Next, please. So in the old criteria, it wasn't like the DSM-5, which is right now. It could be called Asperger's. It used to be called pervasive developmental disorders. But now with the DSM-5 criteria, it all comes under a spectrum. It could be level 1, 2, 3. It could be high functioning, severe functioning. And in fact, in the last year, there's been papers that are calling for profound autism, basically children who need significant amount of help. And so the way that we come to diagnose autism is through domain A and domain B. In domain A, you need to meet all 3 of the criteria. And that criteria has to do with social engagement, right? So reciprocity. I'm not in this wonderful conference in person, but I'm still able to maintain eye contact. I'm using a lot of nonverbal gesturing, right? So there's a bit of reciprocity, even with strangers. So that's a significant part of social communication. And then the lack of understanding and communicating your needs. So all of that comes under domain A. And then for domain B, it's 4 criteria. So needing strict routines, getting upset by changes, stereotypies, so flapping your hands without any trigger, rocking. So 2 out of 4 of those, along with 3 of domain A, meet the criteria for autism spectrum disorder. Now, when I tell my families, so my patients are like my families, their parents are also my family. So that's how I'm going to refer to them as I go through this presentation. I tell them it's not about making these children have 100 friends, right? It's not about making sure every child is socially there and very extroverted. It's as simple as sometimes if I'm saying fire, there's a fire. A child with autism might not understand the seriousness, the tone. There's a fire, run. And it's so important that even if you have a speech delay, to understand intonation. So much of social communication has to do with understanding stress, understanding when there's danger, understanding when you need to stop crossing the street. And really, that's how important it is to support these children because of the danger of not understanding social cues. So social cues is not about being the life of the party. Social cues can sometimes be the meaning between life and death, where a parent says, there's a car coming, don't cross the street, right? Okay, next slide, please. Okay, so general developmental screening It usually used to be around 9, 18, and 20 months. And it was to identify the language, cognitive, and motor delays, and really was not that sensitive to social symptoms that was an early identification for autism spectrum disorder. Now comes the MCHAT. What does MCHAT stand for? So this is a modified checklist for autism in toddlers. And really, this should be done at the pediatrician's office. And it should be done as soon as a mom says, I have concerns. A lot of times, if the pediatrician says, oh, you know, give it time, give it time. Neuroplasticity in a child is highest in less than 3 years of age. So key diagnosis, early diagnosis is imperative. Of course, neuroplasticity continues till your early 20s. It continues even after. But there's a reason someone like my husband has a harder time learning Arabic now versus when I was young, I was able to learn Arabic when I was a 5-year-old. And so the pathways of the brain are more malleable in children that are younger. So if there's a parent who says, I am concerned, there is nothing that you lose by just doing an MCHAT. It just takes 15 minutes. Moreover, it's been further validated in ages 16 months and lower. Next, please. So, children who score greater than 8 are at high risk for autism spectrum disorder, or even another developmental order, right? So it doesn't just have to be autism. Could it be sensory integration issues? Could it be a mixture of severe global developmental delay? But the pediatrician's job is to screen. And once there is an indication that something is not normal, you just make a referral to a developmental behavioral pediatrician or to a neurologist or to a neurodevelopmental disability specialist. Now, what happens if the child scores between 3 to 7? Do you tell the child, okay, you know what, come to the next visit and we'll score you again? No. 3 to 7 means it's not normal. And so there's publicly available scripted follow-up interview questions that are required. So you do the additional testing in the clinic. And if the child is still continuing to score in that intermediate age range, that is still a red flag, because there is 47 risk of having autism spectrum disorder in those children who score 3 to 7, and a 95% chance of being identified with another developmental delay. It could be something like an intellectual disability or global developmental delay, and they would benefit from intervention, such as speech therapy, occupational therapy, even school with special education services. And so I always tell our pediatricians when I give these talks in the United States that if you have a child who scores in the intermediate range, there is no neurologist or developmental behavioral specialist who's going to say, why did you refer this child to me? It is enough cause for further evaluation and treatment. Okay, next, please. So those are the screeners, right? Screening means that there's a risk for autism, but evaluation shows, does this child meet the criteria for autism? So in the United States, in many different states, there is the need for insurance coverage, right? A lot of times in the Middle East, it's a self-pay, right? Does the government help? Does the family take out-of-pocket pay? But in the US, you have different insurances that you have to choose from. And if you don't make enough salaries, then there's something called Medicaid. So that is normal insurance in families who don't make enough money, and then the state comes in and helps with that. And so for insurance to cover therapies for autism, it needs that evaluation. And it needs the evaluation from the following slides that I'm going to talk about. So, and even if you don't need insurance, right? You have to get the diagnosis. And so ADOS is the really classical way of diagnosing autism. And what does ADOS stand for? So ADOS stands for Autism Diagnostic Observation Schedule. And it was developed specifically to elicit atypical social language and behaviors. Because what is autism? At the end of the day, it is a challenge in social behaviors and social engagement. And with ADOS, it has a wider age range. It's not just like the MCHAT, right? It can even go up to adults. In fact, the ADOS has different layers to it that is specific to age groups. And the MCHAT can be done by any physician, whether it's a pediatrician or a nurse practitioner or a physician assistant. The ADOS really requires intensive training to accurately administer and score. And it takes 30 to 60 minutes to administer. And in fact, I've seen it when done thoroughly even take 2 hours to administer. And really what the analyst is doing at that time is they're doing things like playing peekaboo with the chat, right? I may meet one of your children, they might not know me, but as soon as they start feeling safe with me, if they don't display characteristics of autism spectrum disorder, they're going to giggle. They're going to feel excited when I start saying peekaboo, peekaboo, right? And then they're going to anticipate that the next time I say peekaboo, they are going to see my eyes, right? And they'll see that expression. But someone who lies on the spectrum is not going to have that anticipation or understand that social cue of interactive play. Another thing that is an example on the ADOS is the playing with bubbles. So when you blow bubbles, and in the day and age of a pandemic, now we can't blow bubbles. So now we get an electronic machine that creates bubbles. And so when the child gets excited, even if they have a language delay or a speech delay, right? But they don't have autistic characteristics, they should be able to point and say, even if they don't know what bubbles means. But a child with autism might jump, might flap. They want to engage in more bubbles because now the evaluator has stopped. But a child with autistic characteristics is going to start getting frustrated, will start crying. They will have issues in engaging and addressing to the evaluator that they want more bubbles. So it is even kids who just have speech delay and don't have autism, they should still be able to use gesturing to show that they want that. And so the ADOS is multiple play activities, but really it's psychological evaluation. The other evaluation that you can do is the Childhood Autism Rating Scale. It's another structured approach as a clinician that might be used to support the clinical diagnosis of autism. And I actually use CARS a lot because, like most of you physicians in Saudi Arabia, you probably have 30 to 60 minutes or sometimes even 20 to 45 minutes, right? So when I see a child, I'm taking their history, I'm taking their exam. A lot of times they might have seizures. And so I don't have 60 to 2 hours just to do psychological testing, right? That's why my clinic has 2 psychologists. However, let's say they're coming from far away, because we are the main neurology healthcare center in Georgia. We also get a lot of patients from neighboring states like Tennessee. And so I find it quite hard for them to leave knowing that in clinic I see the full spectrum of autism. But for insurance to cover applied behavioral analysis therapy, they need that psychological evaluation. So then I'm able to administer CARS, and the advantage of CARS over ADOS is that it's faster. It's takes 20 minutes to 25 minutes. It doesn't take 2 hours. So next slide, please. So what is the difference between ADOS and CARS? That's what I'm going to talk about in the next 2 slides. So ADOS, during this time, the examiner provides a series of opportunities for the subject, the patient, to show social and communicative behaviors relevant to the diagnosis of autism. The selection of an appropriate module is based on the developmental and language level of the referred individual. So if a 3-year-old child has the verbal capabilities of a 1-year-old child, that ADOS is not going to serve them well. So we have different modules that address, minimal verbosity, a few phrases of verbosity, or able to have more language skills. And remember, I said minimal verbosity. So which is non-verbal. That's not non-verbal, right? Minimum means like there's at least some words being said. So the only developmental level that's really hard to assess through an ADOS accurately is that for adolescents and adults who are non-verbal. But hopefully with this wonderful conference that you all have and the more advanced education that we're bringing worldwide, right? That you guys are doing too, is that we won't reach a stage where an adolescent or an adult is undiagnosed if they truly have autism. ADOS should not be used for formal diagnosis in individuals who are blind, who have hearing challenges, or are seriously impaired by motor disorders and sensory issues. Because then you don't know, is it an issue because of significant sensory challenges? I'll give you an example. Let's say you have a 6-year-old child, even though stroke is very rare in children. Let's give them an appropriate risk factor, right? Sickle cell anemia increases the risk of stroke in children. So let's say you have a child who has sickle cell and had a stroke, and the stroke affected the parietal lobe, right? And the parietal lobe is over here, and it controls sensation. So in this child, an ADOS would not serve this person appropriately because you don't know if the sensory issues are due to stroke, and there's going to be a lot of conflict with some of the play therapies that we do, right? Are they not going to feel the touch of the bubbles? Do they not understand how that is formulated? So that's also with cerebral palsy and muscular dystrophy. The other thing to know is muscular dystrophies, in the last 3 to 5 years, we've understood that there's a high association with intellectual disabilities. So like Duchenne's muscular dystrophy, the dystrophin gene that is associated in creating this muscle weakness has now been correlated to cognition in the brain. So there's a lot of false positives with intellectual disability. There's a lot of false positives with ADHD. Now that's a bit interesting, right? Because a lot of kids with autism also end up having the comorbidity of attention deficit and hyperactivity symptoms. So how do you distinguish both of them? And this is actually one of the most common questions I get when I speak in the United States. A lot of physicians ask me, how do we differentiate this? And the way I say it is, of course, if they're happening in isolation and there's not an overlap. Autistic features is you're trying to engage the child and they're kind of not giving you that social engagement. They're probably just looking away. If they're, this is the iPad, they're looking at it. But ADHD is, oh, this pen. Okay. Oh, my friend is just talking to me. Okay, let me talk to you. It's distractibility. So with ADHD, there's distractibility, but they're able to have their attention caught, even if it's just for 5 minutes. With autism, the challenge is even getting their attention in the first place. Many parents will tell me, I call my child's name, they've had the audiological evaluation done where there's no hearing issues, and the child just doesn't respond. And they're very hyper-focused on the task. So notice that's another differentiation. With autistic features, the child can be hyper-focused in that task and not respond to that social cue that the parent is doing to call and get their attention. Okay, next, please. And then next, great, that's perfect, thank you. So now, what is CARS? So I told you this is the other evaluation I do, and this is something I really encourage neurologists and developmental behavioral pediatricians to do, because if you're waiting for that psychologist to do the evaluation in kids with autism, that wait list is becoming bigger and bigger and bigger. And so now this child is going to take longer to get the appropriate diagnosis, which takes longer to get the appropriate intervention. So 20 minutes of your life can really help this child. And so the questions are, and this is something that you assess as the provider and also from the history that you get from the parents. So ADOS is very psychology evaluating through gameplay. This is you observing the child and then also taking history from the family. So how is their relationship to people? A lot of times you'll have one parent say, oh, my son, my daughter is so close to me. My son and my daughter loves playing with my other child. But the question is, how do they play? Are they sitting in the corner and just looking at the sister, or are they in school and just sitting in the corner, or are they understanding how to do pretend play? So a 2-year-old child to 3-year-old child should do pretend play. But by 4 years, they should be having stories. Okay, you are a prince, I'm a princess, you're a doctor. Oh, you know, a full imaginative interactive play. And so when a 4-year-old is not doing that and they're saying, well, there's parallel play, that's a red flag. It should be complete interaction. And children who don't have autistic features are so curious. They want to play with other children. Even if they're shy, they'll still play with the cars together. And their emotional responses, it's not going to be, you're just rocking for no reason, right? And then the other question I get is, well, my child rocks, so has stereotypies, but everything else is fine. And that is okay. If something happens in isolation and everything else is great, they're developmentally appropriate, they're speaking well, they're interacting well, it is okay to just have stereotypies up to 5 years of age. In fact, I'm sure you know a colleague that you work with who, when they're typing their notes, rocks, right? And sometimes it's okay, but it's the whole picture. Okay, they're clapping, but nothing else is going on. They're rocking, but they're not interacting during rocking. And they don't have good eye contact. They have very picky nature to food. So a lot of times with children with autism, you'll hear, he only eats crunchy foods. Mashed potatoes, soup makes him so upset. They don't like noises. If the vacuum cleaner is there, okay, the first time a child hears the vacuum cleaner, they're gonna get scared. But after a few times, they're not gonna get scared by it. But every time the child hears the vacuum cleaner, they'll cover their ears. So that's another red flag. The other thing is pointing, right? It's very easy to ask a parent, does your child point? And they're like, oh yeah, the child points. But what we've discovered is unless you show the parent, you might miss some things. So when then you ask the parent, how do they point? Sometimes they tell you like this, 2 fingers, or like this, or like this, right? So then actually that's not a good pointing skill. The other thing is sometimes they'll say, we'll ask, can your child communicate with you to ask for food? And we're like, yes. But then when you dig in, the mom will say, oh, actually, my son or my daughter holds my hand, takes me to the fridge, and then tells me to, get the orange juice. So then again, that is also a red flag. A child who does not have autistic features should be able to point, but not use mom's hand as a robotic feature. The other thing is, it is fine to have children who meet the criteria of autism. Remember, domain A and domain B. But when we ask about relationship to people, some of them are very close to a parent or a sibling. So then the question is, how are they with other children in school? How are they with their age group? Because again, I have high functioning patients who are great with adults, but they have a very hard time with children their own age. So even though you have these lovely set of questions, as physicians, it is our job to dig in deeper, because sometimes a yes from mom may mean something very different than to actually what we are seeking. Next, please. Okay. So, evaluation. What are the theories behind autism? So this is one of the things that really excite our residents and our training physicians and our young medical students where I work. Is before, the question was, is this from the frontal lobe, which really dictates cognition, right? But so much research has been done in the last 3 years, where the cerebellum is more important than we previously thought. When people think about cerebellum, what's the first thing you think about? You think about fine motor skills, coordination, right? If something is wrong with the cerebellum, do you have ataxia, which means you don't have the ability to walk properly, right? It's this ataxic gait. There's pass pointing, which we call dysmetria. So trying to reach an object, there's pure issues with accuracy. But what we've learned in the past few years is the cerebellum is really important and plays an important role in cognition. And what they learned in autopsies was that the volume of the cerebellum was smaller in children with autism. Now, this is not something you can see on an MRI brain, right? MRI brain, we see any structural abnormalities, any mesial temporal sclerosis, which is a fancy word for a part of the temporal lobe, which is over here, being thickened, that it has a high risk with seizures. So the volume is not something you can see on an MRI brain, but that's something we know. So I have a lot of children, even if they have severe autism, when I get the MRI brain, it's completely normal. And then the mom thinks, or the dad thinks, well, the brain is normal, so why does my child have autism? And so then I explain to them, there are things that we know happens in a child's brain with autism that you cannot just capture on an MRI brain. Now, there's a high association in Fragile X with autism, right? And so with that, they have macrocephaly. They have large jaws, large protruding jaws. They have large head circumferences. And so when there's macrocephaly, you can get an MRI brain and you'll see that correlation. But a lot of times there are some syndromes that are associated with autism where they can have microcephaly, so small head circumference. That is less than 3rd percentile. But again, you have, and you all must have seen it in your practices, we have children with autism that are normal cephalic, so normal head circumference. So in the way the practice of neurodevelopmental disabilities in America has changed is before we used to get MRI brains on a lot of children with autism. Now, unless there's no focal neurological deficits on exam, we have taken a back seat to getting an MRI brain. So we actually don't get an MRI brain once we diagnose autism. And if the muscle tone is good, if the extremities are symmetric in their anti-gravity movements and strength, there's no signs of dysmetria, there's no cranial nerve deficits, then we will hold on the MRI brain, especially if they continue to improve with therapies. Another reason we have kind of decreased on the urgency on MRI brains is we've learned that if it's due to structural abnormalities, there's really little what we can do, right? It's not because of a tumor. It's not because of hydrocephalus, which is increased fluid in the brain that needs surgical intervention. The other thing is, in the last 4 years, there have been studies that have shown that anesthesia can affect development. It's not like long-term development issues. It's not that if you are a child who is meeting all normal developmental milestones, just getting anesthesia is going to devastate the child and help them go backwards in their development. But there's enough data that shows children who are prone to developmental issues, anesthesia regularly is going to slow their progression. So that is also another reason that we don't need to sedate the child with an MRI. Now, by the American Academy of Pediatrics and the American Academy of Neurology and the American Academy of Neurodevelopmental Disabilities, all three agree that once an autism evaluation has been made to do genetic testing. One is Fragile X, the other is chromosome microarray. So the question posed to me is, what do we order, Dr. Rashid Khan? Do we order both? Do we order one? So in Saudi Arabia, if there's the ability to do both, that's what I would recommend. Now, when I used to work in Boston, when I used to work in Texas, when I used to work, in different states, it's very interesting because it depends with insurance coverage, right? So, for example, in Texas, Fragile X used to be covered and chromosome microarray. So chromosome microarray is basically, you get to see major deletions, duplications, and so chromosome microarray wasn't covered by insurance. So then I would order Fragile X. And if that was negative and the child has dysmorphic features, meaning there is features that are concerning for a syndrome, then I would write a letter of medical necessity to the insurance to have my child do the CMA. Okay. In Georgia, it's the opposite. The CMA is covered and Fragile X is not covered. So actually that's better because CMA has more genes. Now, the question is Fragile X caught on CMA? So Fragile X is a trinucleotide repeat. That means the DNA, the nucleotide, the CGG, that is repeated up to 200 times for it to be a diagnosis of Fragile X. So trinucleotide repeats are not caught on CMA. So if a child has the features of Fragile X, then you need Fragile X. The other thing is what we've learned in the last 6 years is the 200 repeats is what makes Fragile X positive, right? That is highly associated with autism. But what we know is repeats, because nothing in life is, okay, this is the line and this is where the symptoms start, right? Just like autism spectrum is a spectrum. So Fragile X, what we've noticed is between 50 to 200 repeats, these kids still have intellectual disabilities, autistic features, and even something called Fragile X ataxia tremors-like syndrome. So that means they might have a funny gait. So always ask families whose children have autistic features and X means X chromosome. So it's seen more in males compared to females. So always ask them, did you ever have that uncle that was clumsy, that had a bit of issues at school, that was failing school? And you'll be surprised of like, oh yeah, there was that uncle that used to fall a lot. He was never great at school. He used to get fired from the job. So that's a orange flag too. Is this hereditary? The other thing is what I tell parents when the MRI comes back normal is there's a lot of things that cause autism that you can't see. One is the neurotransmitters. So glutamate and glycine have been shown to be abnormal, whether it's at the receptor end or in the amounts. And these are also the same things that are associated in epilepsy. And sorry, doctor said, okay, perfect. They're telling me I have 15 minutes left, which is all I need. So in epilepsy, there is also glutamate and glycine abnormalities, right? So this means there is a 33% risk of children with autism having epilepsy. So every time they come to my clinic, I ask them, does your child have staring spells? Because staring spells can be absence seizures or any type of seizures. Okay, next, please. So after diagnosis, there needs to be early childhood intervention, right? So applied behavioral analysis is the therapy that is most evidence proven to help with autistic features. And if they have fine motor delays, language delays, they also need speech and OT, occupational therapy. Always make sure you've done a hearing test, right? What if they've gotten these therapies and they're not improving? Is there any associated hearing issues? So early childhood evaluation is great. The other thing we have in America is a lot of schools incorporate therapists in pre-K and kindergarten. So that's a wonderful thing we have here too. And I think they're incorporating this in the Middle East. Next, please. So sleep, remember the hormones, the neurotransmitters is affected in sleep too. So always ask about sleep. Is it associated with obstructive sleep apnea? Is it interrupted nighttime awakening? And melatonin has been great. A lot of these kids are iron deficient. Iron deficiency is associated with poor sleep. So just as a pediatrician, give some iron and it may help the family. Next, please. And we can move to the next slide. And if it's stuck, it's okay. I can go and talk about it. There you are. Because these kids have such a hard time communicating, they get frustrated easily. But also because of the neurotransmitters, they do tend to have more aggression. So it's nice to give these families a handicap placard because then mom goes to the grocery store. If the child runs away, it makes her life easier to be parked in front. We have these two medicines, Abilify and Risperidol, that are FDA approved in children 5 and 6 years older that helps with behavior management. So the aim is not to make them zombies, just calm down a bit to receive the therapies, to be safe towards themselves and others, but this has to be in conjugation with behavioral therapy. We don't just like throwing meds in a child who doesn't need it. It's only when they're a danger to themselves. And a lot of these times, these kids respond to it and they are able to listen to the therapist and learn amazing tactics. Okay, and skills. Next, please. So we just talked about the medical management. So when these kids are on these medications, you need to check the blood, hemoglobin, platelets, or CBC, the liver function, a CMP, so AST, ALT, the liver enzymes. So let's make sure that they're tested every 6 months if you're on that. What do you give young children who are less than 5 and Abilify is not FDA approved or Risperidol? Depakote, which is also a seizure medicine, is a great behavior medicine. So anyway, we give it to kids who are 2 years of age who have seizures, and we know the same neurotransmitters are affected in autism. So I have many children where Depakote has made their lives and the family's lives better. Trileptal is another great behavioral medication too to keep them safe. Next, please. Okay. Really, there is no medication that stops the rocking and the flapping. They tried antidepressants in older patients that was thought to help, but there was no data that this helped in young children. So for stereotypies, we don't treat with medicines. Sometimes the child needs to rock just to calm themselves down. And it's very different from hitting yourself or hitting others, right? A stereotypy is not a danger to the child or to others. So ABA therapy is the best to improve stereotypies. Next, please. So resources. AutismSpeaks.org is available in 13 languages. So that's a great resource. The next three, Autism Society, Autism Self-Advocacy Network, and CDC's Disability and Health Program are not just targeted to children who have autism, but also adults, because we don't just have to support our children with autism, but also adults who have ASD. So these are some wonderful websites that can be used in families worldwide because the resources apply everywhere. Next, please. And these are my references. And you know how to get a hold of me if you have any questions that aren't answered within this day of wonderful conferences and speeches. You can always email me, and I'm happy to help and address anything in the future. Thank you so much for having me. And we can go to the last slide, which is the end point.
Thank you very much, Dr. We have room for one or two questions. If anybody has any question. I know our time is tight and we are canceling some of the breaks, but if anyone has pushing question, please. Otherwise, we can move to the next speaker. I think we have your contact, and we'll be happy to communicate with you as time passes, or anyone has any queries, he can approach the organizers, he can link you with the keynote speaker from the United States of America.
Thank you so much. Ma salama.
Thank you very much. Ma salama. Okay, so now we'll have just a few minutes to separate this hall in two parts so that the workshop will be in the back of this workshop. We'll go for the next talk, which is about genetics of neurodevelopmental disorders. And it's going to be presented by Dr. Noura Saleh. Dr. Noura is a consultant genetic and precision medicine at King Abdullah Specialized Children's Hospital, King Abdulaziz Medical City, National Guard, Health Affairs. Graduate of King Abdulaziz University College of Medicine and pediatric residency at St. Joseph Regional Medical Center, affiliate with New York Medical College, New York, New Jersey, Medical Genetics and Genomic Fellowship at Stanford University, California, USA, and American Board of Pediatrics and American Board of Medical Genetics. So welcome, Doctora. And if you save us time, will be great. Thank you very much.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for inviting me to the first conference of the National Developmental Behavior Disorder Program. I'm very honored to be here today. We can start with the slides, so we'll go. I'll try to be quick. You know, it's very heavy in genetics, and make it as simple as possible. طيب هو ما في مونيتور هنا؟ يجهزوها من هنا. طيب السلام عليكم ورحمة الله وبركاته. Sorry for this little glitch بس إن شاء الله نحاول to go quick. I was asked to alternate شوية عربي شوية إنجليزي as much as possible بس في ال study of genetics حتى بالعربي شوية confusing بس إن شاء الله. So my topic today will be about the genetics of neurodevelopmental disorders, updates in diagnosis and clinical implication. I have nothing to disclose. So the objectives is to define what are neurodevelopmental disorders, what's the genetics behind it, and the utility of genetic testing. متى نستخدم genetic testing? What is the diagnostic yield? يعني أي genetic test you're going to use, and what is the percentage I'm going to get a positive result from it. And also, what is the future in genetic testing in neurodevelopmental disorders. هذا قفز شكله يبغاني يخلص بسرعة. Okay. So neurodevelopmental disorder, they're characterized by inability to reach cognition, emotional or motor development milestones. They have a heterogeneous etiology and lead to impaired cognition, communication, adaptive behavior, and psychomotor skills. It constitutes a serious health problem and affects more than 3% of children worldwide. Most of these individuals have a diagnosis captured within the DSM-5, which includes intellectual disability, global developmental delay, communication disorders, autism, ADHD, etc. And some of the neurodevelopmental disorders are not included in DSM-5, like, for example, cerebral palsy or schizophrenia that has a confirmed biological cause. I think I'll just ask you to do next. Because this just skips slides. Because there's insufficient information to allow a systemic classification of neurodevelopmental disorder. So ما عندنا يعني تقسيمة للdevelopmental disorders بناء على الpathophysiology or mechanism كيف إنها حاصلة. فالتقسيمة تكون about the phenotype or symptoms and signs. So that's why we have the ADHD. It just describes the disease, attention deficit hyperactivity disorder. Next. So identifying a potential genetic cause is vital for understanding the molecular mechanism responsible for the onset of these disorders and also for delineation of genotype phenotype. So أي mutation أو طفرة تكتشف في الحمض النووي تبع المريض بيكون لها يعني الوضع الكلينيكي تبع المريض يختلف حسب إيش الطفرة فين مكانها وإيش نوع الجين وإيش وظيفتها في الجسم. So, and it could help more in the progress, understanding the progress of the disease and also to foresee any complications in the future. Next. So this is just a little bit busy slide that tells you how genetics affect the clinical presentation. So you see the arrow on the top is the mutational load, and the arrow on the bottom, which is gene vulnerability. All of them, the more they go to the right or to my left, you'll have a more complex phenotype. So the clinical presentation. What does that mean? Gene vulnerability يعني الجين هذا نفسه قابل إنه دائما تكون فيها طفرات. فإذا كان هذا الجين الفاريانت اللي فيها أو الطفرات اللي فيها قوية أو تسبب مرض فنادراً تكون موجودة في المجتمع لأنها إذا سببت مرض في الشخص هذا ما يقدر يجيب أطفال أو ينقلها للnext generation. الopposite اللي هو variants in genes they're less vulnerable means there is mutations في طفرات في هذا الجين ولكن ما تأثر عليها فتكون موجودة وتنتقل من جيل لجيل بدون يكون لها تأثير واضح. So that's why they say they don't undergo negative selection. These are called common genes, mutations, which everybody has them. And the other one is pathogenic gene mutation, where if you have it, you will have the disease. Next. So this just explaining the inheritance of how a genetic neurodevelopmental disorder, either intellectual disability, global developmental delay, or autism, may be inherited. So it's either de novo, meaning the mutation is only in the child, الطفرة بس موجودة في المريض ما ورثها لا من أمه ولا من أبوه، أو تكون طفرة من الأم أو من الأب ويكون عندهم أعراض للمرض. بس عادة في genetic disorder or neurodevelopmental disorders, they're severe enough that they are not reproducible. Going back to mutational load. So for example, these two genes, they cause a specific phenotype where the patient will have variable clinical presentation, intellectual disability, autism, seizures. But in the other square, where it says autism recessive disorder, if he has mutation in both copies of gene, one came from the mother and one came from the father, the phenotype is different now. It's not just variable intellectual disability, autism, it progresses to epileptic encephalopathy. So يكون عندهم أعراض أشد. عادة تكون الأب والأم يسموا ناقلين. الناقل زي ما واضح في الصورة they're heterozygous، يعني نسخة فيها طفرة ونسخة ما فيها طفرة. الناقل قد يكون سليم تماماً or عنده mild phenotype، عنده أعراض ولكن طفيفة ما هي واضحة يعني مرة. Dual molecular diagnosis mean you have a double diagnosis. This is very common in our society because of the consanguinity, and so it's not rare to find a child that has autism due to a specific gene and has seizures due to another syndrome or disorder. So that affects the phenotype. So ما تقدر تقولي إن هذا الطفل بس عنده autism ولكن شديد، لازم تتأكدين إنه ما في مرض ثاني هو اللي أدى إنه يكون الصورة الإكلينيكية تبعه أشد من الطبيعي. Next. This is two-hit hypothesis, which is this last slide mostly goes with autism, that when you do genetic diagnosis you don't find a clear single gene أو طفرة في جين معروف إنه بس له علاقة بالتوحد. So the two-hit hypothesis meaning عندك طفرة في gene, for example this gene, you have this mutation in all your cells in your blood and you don't have a clinical picture because you have another copy that is working. Then you pass this mutation to your child. The child gets a second hit, meaning إنه هذا الطفرة ما هي موجودة في الدم ولكن بعد انقسام الخلية وتكون الجنين في مرحلة من المراحل ظهرت طفرة في النسخة الثانية. فhe has now two hits في نفس الجين. That's why he will have a more severe phenotype. اللي عنده one hit عادة يكون بس عنده يمكن تشنجات بسيطة. بس if you had two hits حيكون عندك brain malformation. So you'll have abnormal MRI of the brain. Genetic predisposition, this is what we talked in the previous slide about common variants. So everybody carries common variants for different genes. They interact with each other, either with location or function, but they don't affect you per se. But if you marry somebody that has the same common gene as you, and then you pass on to your children, and as you pass down generation, this will increase your predisposition to specific genetic disorders. لأنه as you see in this picture, say this mother has two common mutation and common variants in genes ما أثرت عليها والأب نفس الشيء ولكن مع بعض سببت مشكلة للطفل سواء صعوبات تعلم ما حتكون بشدة مرض وراثي معروف الطفرة في الجين. هذا الطفل لو عمل تحليل جينات ما حيطلع فيه نتيجة، حيقول لك نيجاتيف لأن هذه الطفرات تعتبر طفرات طفيفة وموجودة في المجتمع موجودة في شخص سليم. They're not going to report it in the result. So you have to keep that in mind. Next. So recent studies have demonstrated the significant portion of neurodevelopmental disorders, زي ما ذكرت, they're polygenic in nature, can be attributed to common genetic variants, زي ما ذكرت. The additive effects of these mutational events result into disease phenotype. The phenotypic outcome depend not only on the sum effects of a single mutation, but also physical and functional interaction between different genes. Most of the neurodevelopmental disorder cases, they're likely to be multifactorial or polygenetic in nature, confirming the broad heterogeneity of these disorders at both clinical and molecular levels. Next. So the utility of genetic testing in neurodevelopmental disorder. Identification of the genetic etiology for the disease is significant ramification of genetic counseling and patient management. الأهل لما يجوا نبغى نعرف ليش عنده هذا المرض، هل هو وراثي، هل بيجي أولاد ثانيين، طب هل هو بس عنده توحد، هل بيجي تشنجات، هل توحده خفيف، هل توحده شديد، فأسئلة كثيرة إحنا يعني ما حنقدر نعرف إجابتها. وجود طفرة في جين معين عليه دراسات سابقة أو في مرضى تم ذكرهم في الليتريتشر حيساعدنا نقول أهل إيوة في 10 في 20 في 50 شخص مثله، وهذا كان البروجرس تبع الديزيز فيهم، فنتوقع هو will follow the same pathway. Leads also better assessment of recurrence risk, as we said, possibility of complications, enable families avoid unnecessary diagnostic testing. يعني خلاص إذا عرفنا الطفرة ما يحتاج نعمل MRI, LP, any invasive testing. خلاص we know the gene and we know the syndrome. Can be provide families explanation of the child developmental history and also bring the child يعطيهم peace of mind. خلاص closure. We know what he has. Now we can move on. It's not our fault. ما هو شيء أكلته أو شيء شربته أو حاجة عملتها أثناء الحمل وهكذا. Next. So this is just quick example. This young man is a 22-year-old with intellectual disability. He's dysmorphic. You can see he has big jaw, big head, big ears, ADHD, autistic, and he's the only affected family member. You can see from the picture, the mother and dad are related. Next. So in this case, as Dr. Khan described about the first genetic test they usually do. So this is just a quick summary of each academy: American Academy of Child and Adolescent Psychiatry, American Academy of Pediatric, and of Medical Genetics. They all go around the same guidelines, which is initially start with chromosome microarray and followed by Fragile X testing. But as we move on year by year, this may take a second hand, and we'll probably move more to next generation sequencing than just starting with chromosomes. Next. So I'm going to go through different genetic tests. I don't know how to هذا الشرح شوية فيه بيكون صعب بالعربي، بس هذه الكاريوتايب أو تحليل الكروموسومات الصبغية. A karyotype, this is the picture of it. So basically it tells you if this is, there is an extra copy of a chromosome or large structural rearrangements, also for mosaicism. It does not detect segments smaller than 5 to 10 megabase. So if you're looking for a specific syndrome, you know that the deletion is smaller than 5 megabase, this test will not help. So you just skip this test. It can diagnose William, which the deletion is big, or trisomy 21. Next. A fish study, it's like you use a probe. You can move to the next slide. So I expect a picture. So it's basically fluorescent. They use a probe. They highlight it to a specific location on the chromosome. So if you highlight, say, the area you're looking for example, this patient with DiGeorge syndrome or 22q11.2 deletion syndrome. So we highlight fluorescent 2 probes to that area. So he should have 2 copies, one from mom, one from dad. And then the other 2 fluorescent is for control, to make sure that there's other 2 chromosomes. So the normal, you can see 2 red highlights. The green is 2 green highlights. So this is normal. There's 2 copies in 2 regions. While in the abnormal, there's only 1 red highlighted. So he's missing the DiGeorge critical region. That's why he has the syndrome. Next. Array CGH or chromosome microarray. This is the standard first test you will do for any child with developmental disorder, congenital malformation. It basically multiplies thousands of genomic regions and chromosomes, and it can detect copy number variants more than 250 kilobase. So it's small, but the fish can detect smaller. And it also can detect areas of homozygosity, meaning if you have 2 chromosomes, there's areas of it, if it's exactly the same, مطابقة يعني تكون منطقتين مطابقة لبعض، هذا يدلنا إنه الأهل they're related. So this tells us there's consanguinity in the family. Or if both whole chromosomes are exactly the same, they can lead to specific syndromes we'll talk about in the next. Next. So this is just a picture of how array CGH goes. You put the patient sample with a control sample, and then you put it in the machine. So the control to the patient, and then you'll detect the copy number variance. The green is deletions, and the red is duplication. So the green means there's a missing part in the chromosomes, and the red means there's an addition part in the chromosomes. The next picture, so you can see the mother. This just explains a terminology called uniparental disomy, which is important for some of the neurodevelopmental disorders. So normally, you'll get one red from your mom and one blue from your father, so that's a normal child. This is, say, it's chromosome 15. Let's say you have 2 copies of chromosome 15 in your body, one from your mom, one from your dad. If the second one happened, it's heterodisomy, meaning both copies, you took it from one parent. So this, if you got uniparental disomy, both 15 chromosome from the mother, you will develop a syndrome, which is Prader-Willi syndrome. This is for chromosome 15. This is an example. Isodisomy is another example of uniparental disomy, but when does this happen? SubhanAllah, this is with monosomy rescue. So when you have monosomy, this chromosome will make another copy, so the baby can be viable and continue. Next. This is another test you use. It's called methylation-specific MLPA. So this detects areas of methylation in the chromosome. The results of this test, they don't come and tell you there's normal or negative or positive methylation. There's areas in your chromosome, they are methylated, meaning they're silenced. And there's areas that are not methylated. So the result either comes, there is abnormal methylation, so that will be the report. Where can you use this? Patients like Prader-Willi syndrome. So in Prader-Willi, the Prader-Willi area is from P, we remember, is paternal. So in the 15 chromosome from the dad, there's a Prader-Willi area, it's active. The 15 chromosome from the mother, it's inactive. So when you get both chromosomes from the mother, both areas are inactive. So you'll have Prader-Willi syndrome. So when you do the methylation test, you'll find both areas are hypermethylated instead of having one hypo and one hyper. So that you'll have. Also Beckwith-Wiedemann, you use that test as a screening. And then after that, you can go stepwise finding why is there abnormal methylation. Next. This is example of disorders that cause due to repeat expansion. Number one, you can see Fragile X syndrome, which is the most common test that they use in the neurodevelopmental disorder. But there are other disorders that you use this test for, which is called PCR or Southern blot. So you need to understand that if you do chromosome CMA or methylation test, you're not going to detect Fragile X syndrome. So we have to understand the mechanism of the disease to know what test to send. Next. Now this is the revolution, which is next generation sequencing. The breakthrough of next generation sequencing technology has led to significant advancement in identification of genetic cause of neurodevelopment disorder. It refers to a large scale of DNA sequencing technology that allows for querying the entire genome. Exons within all known genes is called exome, or genome including exons and introns. So next generation sequencing, you can use it either if you want to send a single test, you know this disease looks like a specific disorder, you just order that test, or multiple gene panel. There's multiple labs that does autism or ADHD gene panels, but keep in mind that these panels are different from lab to lab. So some labs have 20 genes, some labs have 300 genes, so you need to know what you're looking for. Whole exome sequencing, which is the standard that we use now as a first tier, including with the CMA. Whole genome is on the way, so maybe in the future, in a couple of years, it will substitute whole exome and we'll just go straight whole genome, because whole genome also can detect CMVs and also can detect repeat expansions, so if you're looking for Fragile X. And then part of the cell, which is the mitochondrial genome, we shouldn't forget that if you're suspecting. To date, there's more than 900 genes responsible for X-linked, dominant, and recessive neurodevelopmental disorders that have been reported. Next. These are different databases, so we have multiple, either Decipher, we have the Saudi Genome Program, Genome AD, that have different genes, different variants, and what disorders they're linked to. They also have variants in genes that are candidate genes, mean that there are new genes we didn't discover their relationship to a disease yet. So these databases are very useful. We use it every day. It's not only geneticists, so if you find any report of a variant in a gene, either whole exome, whole genome, you can look it up in this database and see if it's truly disease-causing or not. So going back to our case, so he had karyotype done, was negative. He had CMA done, negative. Fragile X done, was negative. So then we moved on to whole exome sequencing. And lo and behold, he does have Fragile X syndrome, but he has 1% of Fragile X syndrome that have Fragile X due to mutation instead of repeat expansion in the gene. So he has a point mutation, which is rare. Next. So the diagnostic yields of these genetic tests. The current evidence suggests that among patients that have intellectual disability or global developmental delay, the diagnostic yield is 15% from CMA, which is chromosome microarray, 35% from WES, whole exome, and 1% in female, 2% in male from the FMR gene testing. Diagnostic yield of those primarily with autism, they're at least 10% of CMA, 15% in WES, so it's not as high if you have intellectual disability or global developmental delay, and 0.5% or less, the Fragile X testing will come back positive. So across all these tests and clinical diagnosis, the diagnostic yield rates are higher in the presence of lower IQ, neurological comorbidities, dysmorphic features, and congenital anomalies. Therefore, the cumulative diagnostic yield of all these tests is over 50% for individuals with ID and global developmental delay, and over 25% for individuals with primarily autism syndrome, autism spectrum disorder. Some studies report a higher diagnostic yield with WES trios, meaning having both parents and the child be tested at the same time. Next. So up to date, just to give you a picture, we have 20,000 genes located in 46 chromosomes. To date, we only know around 4,000 to 5,000 genes that are linked to 7,000 phenotype. So do you understand that we only know around 5,000 of the 20,000 genes? So even when you have a negative test, we're still learning more and more month by month. So negative doesn't mean he doesn't have a genetic predisposition or mutation, or it could be recurrent. This is explained thoroughly to every parent coming to do the test, that negative does not mean 100%, but at least what we know from the disease, it's not from it. Okay, next. So advanced in genetic testing, now there's something called RNA sequencing, which is skipping the DNA, you're going downstream and seeing how the effect of the RNA, because some mutations you don't know. Is it pathogenic? Does it cause disease? So you skip to the RNA. If there's a problem in the RNA, then you know that that variant is pathogenic. Also genome-wide methylation studies, single cell omics or metabolomics, computational models, bioinformatic network analysis, CRISPR-Cas9 gene editing. So now they edit that, they add the mutation in animal modules like mouses, and then they see the effect in the mouse, and then they can understand the pathway, and this will lead, inshallah, to future targeted treatments. Next. So in conclusion, most of the neurodevelopmental disorder cases are likely due to multifactorial and or polygenic nature. Recognition of the NDD causing gene is crucial for accurate genetic counseling and patient management, and represent an essential first step toward a better understanding of the molecular pathway affecting these disorders. Genetic testing is now the standard of care for several neurodevelopmental disorder, and indications for testing will broaden in the future. The implementation of next-generation sequencing technology in the diagnostic flowchart has dramatically increased the percentage of patients who receive a molecular diagnosis. And the advances in this field has served as a roadmap development functional genomic studies, almost understanding the pathogenic mechanism associated with these reported mutations, and can lead to identification of potential targets, thereby opening prospective future treatments. Next. Thank you.
Thank you, Dr. Nora, for this very comprehensive review of genetics and neurodevelopmental disorders. Are there any questions? can have 1 or 2 questions at max. Time is a limitation. Thank you very much, Dr. Anur. And you'll be around for anyone who has questions and queries. Thank you very much. The third talk today is going to be virtual and will be presented by Dr. Anur Mdehish. She is a consultant child psychiatrist, King Saud Medical City, King Khalid Hospital, and CBT in and she's the director of she was the director of child health in King Khalid University Hospital. She will speak for 20 minutes about ADHD in the context of autism spectrum disorder, assessment, rating scales, and treatments. The floor is yours if you're ready. Dr. Nora.
أتمنى الصوت واضح؟
واضح الصوت. Go ahead.
طيب بسم الله. بسم الله والصلاة والسلام على رسول الله. حقيقة حابة أتكلم اليوم عن موضوع مهم وإن شاء الله ما تكون محاضرة ثقيلة عليكم بعد محاضرة الدكتورة نورة ما شاء الله كفت ووفت عن موضوع الجينيتكس. So today we'll be talking about ADHD in the context of in the context of ASD. Sorry, I didn't put it on the Okay, so I'm going to talk about what do we know and how can we approach those patients. As they are very important categories and there is clinical challenges in those cases. So I will be covering in a brief what are the changes between DSM-4 and DSM-5, what is the overlap between them, and the assessment and use of rating scale in those population, and what are the modalities of treatment for sure. So first of all, I would like you, I don't like really to always put a lot of the slides about articles, but it's only to compare how the things have been changing through the time. So I just put this article, which was published in 2010. I just want to highlight something very important. This article exactly matched the name of our lecture today, Attention Deficit Hyperactivity Disorder in the Context of Autism Spectrum Disorder. And it was published in Current Psychiatry in 2010. As you can see here, as I highlighted, DSM-4
دكتورة
preclude
السلايدات ما هي طالعة did you share it with us؟ طلعت في البداية بعدين اختفت.
نعم.
الآن أوكي؟ الآن أوكي. go ahead كملي معليش. go ahead. هذه أول سلايد موجود.
نعم هذه تمام. This is the article that I just quote, the Attention Deficit Hyperactive Disorder in Context of Autism Spectrum. If you can see, we don't need to read all the article, but I highlighted this thing. So, لا عفوا أستاذ محمد السلايد اللي قبلها. أيوه. لا اللي قبلها معلش. أنا حاطة شير سكرين من عندي ما أدري واضح عندكم اللي. أيوه okay. This is the one. So DSM-4 textifies precludes a comorbid diagnosis of ASD and ADHD. I put it in red light, which means that in the DSM-4 there was no possibility that ADHD can be diagnosed in those population who are having ASD. And their argument was because ASD is the more severe disorder within the diagnostic hierarchy. Any inattention or hyperactivity or impulsivity observed can be thought of a stemming form of a primary disorder diagnosis of autism, which means simply that under the umbrella of pervasive developmental disorders, as it was before named, the severe one is the autism. So any other disorder that have similar symptoms, such as ADHD in certain part, which is the attention part, shouldn't be fulfilling the criteria of diagnosing ADHD. While we can see here in the Journal of Research of Developmental Disabilities in 2014, and it was immediately after the development of DSM-5, the things have been changed. So there is an overlap in the symptomatology, often complicates the differential diagnosis, and the children with ASD commonly receive a diagnosis of ADHD in the first, and that's the thing that we will come later on. And they notice there is increase of rates of ADHD within the ASD population ranging from 20 to 70%. So if we notice the change, there was a big change from DSM-4 to DSM-5, which means that they allow to diagnose the comorbidity between the ADHD with the autism, and this gives a question that are we missing some cases before? I can't tell about this, but unfortunately, yes. And there are different articles. Some of them will put the rates between 28 to 86%, and the other one put like from 40 to 70% range of comorbidity of ADHD to the ASD. And the main question, why do you think those disorders overlap? Actually, we have many explanations for this. The first thing is that because both of them are neurodevelopmental disorders, both had onset in childhood and shared genetic heritability. And Dr. Noor just talked about those genetic details actually. But I'd like to explain more about how do we describe these things in the context of a neurodevelopmental disorder. So the genetic heritability was studied by twin studies. And what do we mean by neurodevelopmental disorder? Because if we go back to the DSM-5, which is the main stem for diagnosing those disorders for children, we will find them under the same umbrella, and which means that it is a pervasive disorder that have an effect on the social and communication, development, milestones, everything is affected. So they put those disorders in the same category. The other thing is that they put a theory that maybe they share the common latent phenotype construct, or could be there is a substantial measurement error or reporting bias, which means that sometimes if the child comes in the early stage, there is a focus of the family for the developmental milestones. So they will have a diagnosis of ASD. While if this child, the same child, comes to the school age and they face the same struggle, but in another setting, which is the school, regarding the academic or social communication, being distractible, inattentive, he will receive the diagnosis of ADHD. The other factors that the neuroimaging study showed another also possibilities that why they share the same presentation. There is a reduction of posterior cerebellum specific to the ADHD, while there is in the ASD an enlargement of the left middle superior temporal gyrus. So what do we mean by that? Although there is structural abnormality in different areas, both unfortunately share the presentation clinically, which is delay in maturation of attention and executive functioning, and eventually the social communication. Another thing, the social functioning, which is the absence of positive behavior in ASD, while in ADHD, presence of negative behavior. And what does this mean? If everyone can speak Arabic well, I can say like, this child usually comes in the beginning. For example, let's say that a 7-year-old child who was previously diagnosed as ADHD, while he came to school and he received this diagnosis, or the other way around. Let's say that he was diagnosed at 5 years old as ASD, and then when he comes to school, he can't be attentive, he can't be, maintaining the structure. So what we notice externally is the externalizing behavior. We call the disruption, the impulsivity, the hyperactivity, while inside, as ASD diagnosis, he is actually sensitive to the stimuli, the external stimuli, could be auditory, could be tactile, could be olfactory, whatever the reason. The child is not quiet as the other kids, so he will be very disruptive, but he cannot express it unless he come to the challenges, which is to be like remaining in the class and following the structure. Also, they share the same problems in executive function. So what do you mean by executive function? It's اللي هي بالعربي الوظائف التنفيذية. So it's the mental process, simply the mental process that to plan and focus and remember. It will be impaired in both ADHD and the autistic child. So they both share those things together, and which brings a confusion, especially in the first early years of the diagnosis. Another thing is that the multiple problems such as stereotyped, challenging behavior, and various forms of psychopathology occur again in the conjunction with ASD. Those conditions affect the variety of positive response, so as adaptive behaviors. And what do we mean by adaptive behavior? Which actually it's the behavior that allow the person to act independently. I mean, like starting from daily life things like cleaning, even communication, self-care, personal safety, to cope with their environment, all these called adaptive skills. If the child is not able to have a flexibility to learn these things, he will be apparent look like ADHD. And I know this is a little bit confusing, but I want you to think about the cases that you encounter. So we will look at them from different perspective, and you will feel that there is really a lot of overlap between those things. And because the ASD, they present with cognitive inflexibility, so they are fixed and they have routines and they are rigid about these things. So internally they are holding all this together, and eventually they will present with aggression because they can't really cope, and they cannot let's say cannot cope with the external environment requests. So they will appear eventually as aggression. So we are seeing now the external part of it, while ADHD is associated with cognitive disinhibition, which means that the child actually doesn't process the information well, doesn't understand what's the risk thing, does not pay attention to the details or even the outcome of his or her behavior. So eventually what we are seeing externally is the aggressive behavior and disruptive behavior. So we got mixed between those two things. Another thing is the psychosocial problems are more prevalent in children with ASD plus ADHD, regardless of the behavior dimension that were examined. So although the previous slides were talking about those overlap, but actually, regardless of what's happening, we should really pay attention to what is really present right now. And ASD plus ADHD are more adaptive functioning impairment, so they have the highest rate of tantrums. And this is what we talked about just a little bit before this slide. So they don't have actually the adaptive functioning doing well, so they don't use it, so they don't process the things, they don't understand the real situation when they need to follow the rules, when they need to be structured, and they have the tantrums, which is the external feature again. And again, also they have both, they share the sleep problems, and they are the commonest, as well as the psychosomatic symptoms. They have a lot of complaints, and as you all know, and mainly the maybe the developmental pediatrics and pediatrics will encounter most of these problems like GIT symptoms, mainly in ASD, and beside the sleep problems with ADHD are most common. There is whenever you have high externalizing symptoms, this means we have a severe case of ADHD. Okay. And when we move to the assessment, of course, I didn't put in the slide that the first thing for assessment is to hear from the patient and the family, to observe the patient in the clinic, to have the history, the family history. The main thing is the milestones. How did this child develop? Because sometimes in the clinic, we are rushing to the clinical presentation of now and what the chief complaint right now. But if we go backward, we can see there are red flags in the beginning that we didn't pay attention to. So it's very, very important that we go backward and we talk about the milestones, the developmental milestones.
دكتورة،
ايوه
احنا في الاسسمنت سلايد اذا بغيتي موف
نعم
بالله يعطيهم قولي نكست سلايد. اوكي لان just to follow up. Thank you. Sorry l'interruption.
Okay. So now we're in the assessment. So it's important that we talk about the milestones in details, and mainly the how the child cope and how the child is having his own adaptive skills. How is he developing that? How is he independent? How he does in the, or she does in the social context. So it's important because most of the families, they don't pay attention unless there is really a challenge. And we mean by challenge that he needs to follow, she needs to follow the instructions, the rules. They need to be remain seated, for example. And the most important thing is the school. So the parents usually panic and they pay attention to the externalizing problem and they rush with this child. And if we talk about rating, so rating scales. So we talked about clinical assessment because it's the important pillar of the diagnosis. So we don't rush to the scales without having, of course, the history and the developmental milestones, the family history, and the social history. And after that, we need to confirm what we have seen. So in general, we don't rely on specific scales that really made to diagnose ADHD in the ASD kids. No, it's about diagnosing ADHD per se and the ASD in itself. So we need to confirm, move please to the next. So we need to confirm this child is having ASD, which is usually made by the clinician, either the psychologist or the psychiatrist, which is called the Autism Diagnostic Interview Revised, or the ADOS, which is more popular, and it is more objective test and diagnostic for the autism beside the clinical presentation. So we confirm that this child is having ASD. Another thing, we need to use the standardized ADHD rating scales to confirm the diagnosis of both of these things. Usually we need the other informant, which are the parents and the teachers. If we could get from the teachers, which is really very, very helpful because we need more than one sitting. So we use, there is an example of Kiddo schedule for affective disorder and schizophrenia present at lifetime version. Although it shows that it is made like to tackle the affective symptoms, the schizophrenia, but it's actually mainly toward the neurodevelopmental disorder, and it's not necessary that you all know about it, but the most important one is in the next slide, please. The ADHD rating scale, fourth version. Although it failed to separate inattention and hyperactivity and impulsivity in ASD sample, those who have normal intellectual functioning, but it is recommended that clinical interviewing following the use of this scale will separate the ASD symptoms from hyperactivity and impulsivity and inattention. It's actually made of 18 items, covers all the items of the ADHD, the hyperactivity, the impulsivity, and the inattention piece. When you have more than 9 items, they scored the highest. They start from 0 to 3. If you have the highest, and you can find like the scoring system in the internet, and it's easy questions, but because of the rights that we couldn't put any sample of that. So if you find it high, this confirms that what you have seen in the ASD. Now we have diagnosed the child, and we have put like, even if you have hyperactivity symptoms, you should go and do this scale because you want to know, is this hyperactivity because the child, next please, the child is being disruptive in the context of social settings. معلش السلايد الثاني treatment consideration. So you want to know, is this child really just got disruptive because of the ASD context, or you need to see if it is like a pervasive thing happening in everywhere. You should consider ADHD in this child beside the ASD. If we talk about the treatment consideration, we should keep in mind that the intellectual abilities of this child is important to assess, because either you will go with behavioral or your medication, and it's actually important to set a limit of expectation for the parents mainly. So if the child having intellectual disability beside the ASD and ADHD, it will make it very difficult for them. And from my clinical experience, they will be on polypharmacy, in which causes a lot of side effects, and we have to be cautious about that. And also you have to make sure about support at school and family support. Actually, it's not always easy to do the things at the school, and we are mainly talking about school because it's the most important challenge for the family. But if you start with the family, with the support and monitoring early signs of ADHD, it will inform a design of early intervention. and which will give an improving in longer term outcomes. Next, please. So the treatment consideration also, as ADHD is presented in ASD, is associated with increased severity and significant increased risk of a third condition, mainly the anxiety. And I would like to highlight for the anxiety mainly because the ASD kids, sometimes if they are verbal, and we call them like high functioning, they will be misleading a diagnosis for that, and most of those kids actually they present like in an anxiety features, but they cannot tell exactly what's really making them anxious. فعلى سبيل المثال مثلا الطفل لما يكون عنده توحد ويعني عنده قدراته اللفظية عالية، لكن لما ينحط في بيئة دائما يعني خلينا نقول تتطلب منه انه هو يتواصل، خصوصا المدرسه، وانا اعيد وازيد على المدرسه انه هي الحد الفاصل دائما للاهالي في يعني طلب النصيحه الطبيه. فهذا الطفل بسبب يعني السنسوري ايشوز اللي موجوده، اللي هي مثلا الحساسيه العاليه للصوت او المنخفضه او مثلا للاضواء او حتى مثلا لمس معين مثلا، او حتى مثلا اصوات الناس الاخرين لما يتكلمون او ياكلون، فهو يتجنب هذه الاشياء لانه ما عنده المهارات الاجتماعيه اللي تخليه يتعامل في ظل هذه الظروف، فيشخص خطأ على انه هو الرهاب الاجتماعي. So they diagnose them with social anxiety disorder and mood disorder because they are avoidant, they are you know, having low self-esteem, they look like depressed. So most of these things, if we dissect the case and we start from longitudinal history, we will find them they have ASD on top of the ADHD, which make them really uncomfortable in those situations. And the most common target for psychotropic medication is the aggression. So if we see a case like ASD and ADHD on top of that, we shouldn't rush to the medication unless there is really an urgency for prescribing those medication to control the aggression. That's why I highlighted the aggression, because ASD by itself, it doesn't have any treatment per se, unless the psychotropic medication, unless there is comorbid things with the disorder. And this is important for the families to understand, because most of them, they will rush for different modalities of treatment, but we have to be also clinically focused that if there is really an imminent behavior that needs intervention, we should talk to them about the choices of medication. If we talk about preschoolers, usually will remain with the behavioral things. The ABA is the gold standard for them, and the behavioral parenting training. So if we next slide please, the treatment consideration. الشريحة اللي بعدها اللي فيها preschoolers. Okay. فلما يكون الطفل في العمر الصغير اللي هو ما قبل المدرسة، الأفضل دائما التدخل السلوكي، لكن لو لاحظتوا ما يكفي فقط للطفل، لازم الأهل. So the parents should learn and train how to trigger those situations that trigger the child, that make him really uncomfortable or aggressive. But if it is severe enough, the only thing that was approved is the methylphenidate in a small dose, which is Ritalin. While in the school age, the evidence-based elementary school intervention for managing ADHD in those kids, we need to have proactive strategies like systemic teaching of classrooms rules, اللي هم عادة القواعد اللي نعطيها نفس الأطفال اللي عندهم ال ADHD، ولكن نكون بحذر أكثر مع ال ASD، بحيث نطلب منهم تكون فيه إذا ما توفرت هي الغرفة الحسية، ممكن إحنا التكامل الحسي، ممكن إحنا يعني نطلب من المدرسة أنها مثلا توفر فصل فيه عدد طلاب أقل، المعلمة مثلا تكون بشكل ملاصق للطفل، مرافق له بشكل عام، علشان الطفل هذا يكون أصلا عنده حساسية عالية للتغيرات، فلازم يكون في أحد يعني يحاول يكون يعني داعم له. أيضا المعلمة لازم تكون، أو المعلم لازم يكون مثلا على دراية بأنه يحتاج هذا الطفل التعليمات تكون بشكل مختصر، بشكل متكرر تعيدها له، يعطى يعني فرصة للإجابة أكثر، ويطلب منها أيضا اللي يسمونها البودي بريكس، اللي هي مثلا أنه يعطى مساحة أنه يعني يرجع يتحرك ويرجع لنفس الفصل. بالإضافة أن البعض يعني يسمح لهم بإحضار بعض يعني مثلا الألعاب اللي هي الحسية اللي ممكن تساعد الطفل أنه هو يهدأ في الفصل. فمهمة جدا كل هذه التدخلات، لأنه في مرحلة الدراسة يكون صعب الطفل أنه هو يعبر عن يعني تضايقه بشكل يحرج أمام الآخرين، فلذلك يقوم يستخدم بعض الآليات اللي هي أو يعني آليات الدفاع الغير صحيحة، مثلا إما العدوانية أو حتى أحيانا الهروب من الفصل. فلازم ننتبه لهذه الأشياء. Academic skill intervention also, which means the assistant in the school from the teacher or special teacher. حتى نعم. I'm about to done. So psychotropics, if you are in need for this, so we need methylphenidate, which reduces the hyperactivity and impulsivity. And we're talking about the school age, which means from 6 years and above. The atomoxetine and guanfacine also have demonstrated efficacy by reduction of 43%. And the efficacy of extended release guanfacine was evaluated in randomized controlled trial and showed significant decrease. So the taking home message that ADHD symptoms co-occur with ASD, in which needs careful and continuous evaluation, especially in younger age group. As you see a severe case of ADHD in the younger age group, you should also question, does this child have ASD? Behavioral intervention for younger age group is the first line of treatment, but with severe ADHD symptomatology, medication is needed. The stimulant is the most studied medication targeting aggression, hyperactivity, and impulsivity. And thank you. And this is my reference. Okay.
Much, Dr. Quick question, please. No comments, only question.
السلام عليكم دكتور نور، لو سمحتي you mentioned إنه if you have a dual diagnosis of ASD and ADHD, what is really your indication to start medication and when will you start it?
شكرا، الله يعطيك العافية. طبعا كل ما كان الطفل فيه يعني or let's say because you asked me in English, so whenever it is clinically severe enough that the patient is really struggling on different situations, let's say in the school, at home, there is a lot of aggression, I recommend really to start medication. And with working with those kids in this developmental disabilities clinic, we found that a lot of them really respond very well when you add ADHD medication if they have aggressive behavior mainly. And this is really the target, because we are not targeting the inattention. We are targeting actually the hyperactivity, the impulsivity, and eventually, if those controlled, eventually the child will improve, because inattention by itself, it's a part of ADHD, but it wouldn't improve by medication alone. So we need to have both the things that we do in the school, I mean, let's say in general accommodation at school, and the medication. Yeah.
Thank you very much, Dr. Allah يعطيك العافية. Thanks a lot. We'll move to the final talk today. It's very important. Also, it's about management of challenging behaviors in autism spectrum disorder, and this very common problem that we have. It's going to be presented by Dr. Ghada Ashmasi, Head of Child and Adolescent Psychiatry Department in Maternity Child Health Hospital in Dammam, and Manager of Developmental Behavioral Pediatric Disorder in Cluster 1 in Eastern Province. She's a graduate of Kingswood Medical City, and she had her fellowship training in Canada, Toronto. So please, you have 20 minutes if possible. Please, thank you.
Now, hello. Today I would like to talk about management of challenging behaviors in autism spectrum disorder. Next slide. Behavioral problems are very common among individuals with autism spectrum disorders. Understanding the functioning of the behavior and positively responding to them can alter the consequences of this behavior. This behavior can include self-injurious behavior, aggressions, repetitive behavior and restricted interest, temper tantrum, non-compliance, and oppositional defiant disorders. Next slide. So, when we talk about the prevalence of challenging behaviors in children and adolescents with ASD, actually in the research it's controversial. Some research said it's around 50%, other research say 18%. According to Autism Research Institute E2 database, more than 2,300 cases indicate that 59% of those with ASD engage in one or more of these behaviors. We are talking about 50 plus of the cases they have behavioral issues. The interesting thing, recent long-term follow-up study found that 44% of the kids when they start with ASD continue to engage in self-injurious behavior decades later. That means some of this behavior persistence. Long-term, if not treated or if not overcome. Next. So the research of ATN, Autism Treatment Network, found more than 50% of autistic kids have physiological aggressive toward others. And the same percent, 50% of the individuals with ASD have engaged in self-injurious behavior at some point of their life, with 25% have behavioral at any given time. The interesting thing, the kids at 1 year old, maybe they have self-injurious behavior. One research, they found around 18.3% of the kids engage in self-injury behavior at the age of 12 months, and like eye poking, self-hitting, and head banging. So what is the risk factor of aggressive behavior? We have to talk about aggressive factor to understand the management. First of all, intellectual disabilities. Approximately 25 of the kids, they have intellectual disabilities, they have aggression behavior or self-injurious behavior with or without autism. As IQ lower and the aggression become more, this is one study they found in adults. The sample of adults with intellectual disability found intellectual disability 5 in the mild, 14 in moderate, 22 in severe, and 33 with the profound. They have aggression behaviors. So as the IQ low, the aggression become more. Other risk factors, genetic factors, notably Lesch-Nyhan syndrome, Smith-Magenis, Fragile X syndrome, they have also aggressive behaviors. Severe delay in communication and social skills. High degree of repetitive behaviors. Also, the study found the kids, they start repetitive behavior at an early age, below age of 3, they have high risk of severe injuries behaviors, and also they have risk of aggression. Severe ASD symptoms, male patients, low socioeconomic class and low parent education. Although low socioeconomic class and low educated parents, it's contradictory. In some research, they said there's no relation. Okay. Also, we have to understand the comorbidity with ASD before we treat the aggression. Autism spectrum disorders frequently associate with comorbid conditions. Around 55 to 70%, they have comorbid condition. The most comorbid condition is intellectual disabilities. Around 38, attention deficit, there's very high comorbidity. Most of the researchers said 30%. And anxiety disorders reach up to 20. Depression, above to 19. Obsessive compulsive disorders, from 7 to 10%. So, and at least common comorbid conditions, psychosis, it's only 4 to 12%. So also we have to understand what some issues, some kids are suffering of sleep problems with ASD. The research found behavioral problems happen more often if the child has trouble sleeping. So if their child not able to sleep continuously 1 hour, he has high risk to stereotype movement and high risk of aggression and irritability. Also, the course of the aggression itself, the kids at early age, they have more aggressive toward other people, while they are grow up in adolescent, 18, and adults more aggressive toward themselves. Although some research they found the aggression decrease with age. So this is nice research about the problem behavior in autism spectrum disorder, association with verbal ability and adapting coping skills. It comparison between 169 of slightly verbal kids and 177 fluently verbal kids. The patients were inpatient. The age was from 4 to 20 years old. The severity of the results found the severity of the behavioral problem not related to verbal ability. If they're controlling the age and nonverbal IQ, they found more relation with coping mechanism. So this is what we would like to work on it in management plan of treatment of aggression. We have to work more on coping mechanism more than anything. So restricted repetitive behavior and interest. What is the restricted repetitive behavior and interest? We have in the ASD verbal like echolalia, motor like forth and back, spinning, flipping, and we have also some RB. The child had restricted interest of sameness. And if we start to provide the kids from this one to become anxious, if we start to stop him from lining up his cards or his favorite toys, he become anxious. And this is cause for him irritability. Research have theorized that sensory problems can initiate RRB. So do we have to treat all restricted repetitive behavior and interest? No, we don't need to treat it all. Only when restricted repetitive behavior and interest are stressful and cause impaired functioning, then we have to treat it. Otherwise, we should not treat. So what's the modality of treatment of the restricted repetitive behavior? ABA is the first line of treatment. Behavioral assessment can help determine the underlying functioning. Rituals and insistence. When we have to decrease spinning or lining up, we have to give him something reward, like to shift him from what he wants. We have to shift him from this lining up the things. We can provide him favorite toy. We can provide him also with attention. So this is a slight reward, and we can't change it. Jogging in some research has shown decrease RRB. Some research they found 15 minutes of vigorous exercise like jogging decreased stereotype behavior. The reason maybe the kids become tired, exhausted. Gradual rewarding is an excellent way to help them to tolerate more routine changes. Child who lines up his cards in a specific order could be rewarded for tolerating slight change in order and gradually increasing the change and reward him for more considerable modification. So we have to change gradually. Not only gradually, also we have to repeat and repeat. Also the reward, we have to change it. Not the same reward every time. and the repetition, one of the successful trials for every child. Some parents come to us to our clinic, we tried this and we tried this. It's not only one trial, it is repetition and repetition and repetition. Next. So some challenging behavior persists into adulthood. Why? Because there is unintentional reinforcement. If the self-injury behavior like head banging and the child earns individuals their desired outcome, like maintaining attention, receiving solid item, or getting participate in preferred activity, this will not stop. It will be continue. So I will not, if I give him what he wants, I give him positive reward. He will continue and continue. Next. The golden rule of ABA: decrease inappropriate behavior, encourage desirable behavior. Research found that ABA intervention lead to medium to significant outcome in intellectual disability, language developmental, improved daily living skills, and social functioning for kids with ASD. And it is the first line management with ASD. Next slide. Next. Okay. So applied behavior analysis, it is first rule on it, understand the functioning of the behavior through observation. What's the functioning? We have to figure out why these kids do repetition, why these kids become irritable. The functioning of the behavior to understand the cause of irritability or aggression. Also in the ABA, we create timeline of each behavior, allows providers to assess causes and potential support strategy, timeline, what happened before, what is the event itself, how it has happened, what's the, after this behavior, what the consequences. So the timeline is very important for assessment. The strategy could include identify the target behaviors. When I work on target behavior, I have to choose one. It's not advisable to choose a lot of behaviors. We start one by one. Antecedent. Antecedent, anything can trigger this behavior. Could be social, could be physical, could be environment. Physical, like abdominal pain, teeth ache, which is very common in our clinic. So consequences, what the outcome of the child he wants. He want to escape from his homework. He want to escape from getting something. What's the consequences? The technique aims to change the behavior through positive reinforcement and make a treatment goal. Always the ABA depend on positive reinforcement. Next slide. So understanding the functioning help the clinician identify an appropriate target of the management plan. Like when the kid has aggression, could be secondary to impulsivity of ADHD, could be secondary to anxiety if he has anxiety disorders, or could be have mood disorder or psychotic disorder. So the functioning, to understand the functioning is very important. So after that, we can put a plan and management plan. The most common functioning is escape, access to preferred activity, internal stimuli. Next slide. So functional behavioral assessment, still I am in the assessment before the management. We have to interview anyone involved with the child. Interview the child himself and anyone involved with him. Teacher, parent, caregiver, anybody. And direct observation. The observation should be in multiple sitting and multiple observer. It is useful to use assessment tools. Why? I can compare the result before management and after management. So some assessment tools like motivation assessment skill, questions about behavioral functioning, function assessment checklist, setting event checklist, and CAI. Next. This is form of assessment, of functional behavioral assessment. Actually, this is free in the internet. You can download it to give you a very nice timeline of the assessment. Like we have target of the behavior, setting, frequency, intensity of the behavior, the duration of the behavior. Next slide. And antecedent, consequences of the event, what's the content of the events. So this is giving us the timeline. The next slide. Also, they can give the factor, like assess the factor. There is any physiological factors, there is any environmental factors. After that, we can put our hypothesis and functioning behavior. What with the frequency of this behavior, so I will assess what's the child he wanna escape from his tour. He wanna has internal stimuli. He feel uncomfortable with some event. Okay. So, and now we are talking about strategy of treatment. First of all, prevention. Prevention we should do before alternate the event before it happened. Like a very common strategy in a prevention, it is visual schedule. We can give him picture of sequences. Okay, I want to train him to go to a bathroom. I will give him consequences of the bathroom. He's feel uncomfortable or become anxious if he change the way to his home from school to back home. Okay, so this is the way. And replacement, replacement. We have to teach the kids how he can replace, like functioning communication training. So I have to teach the kids, instead of he melts down because he doesn't want to do his homework, just ask me, stop, I am tired. I can give him picture. So this picture, if he cannot able, so I understand. Then after the response, the consequences based. So if he show me the picture, I have to reward him, to give him a break immediately. The reinforcement should be immediately. Another replacement mechanism, coping skill, like relaxation, breathing technique, also daily living skills. I teach him how to depend on himself in eating, dress himself. So this is very easy. Next slide. Okay. Next slide. Next. Also, this is very nice study about parent training and parent education, the role of the parents in the treatment. So what we have to do, this is 25 weeks of the treatment of the parents, either by training them to learn strategy, how to deal with their kids, and half of them the education. The end result, the training program is higher than education. The parents, they taught them to strategy of training. They show the parent the improving in daily living skill, as shown by parent rating violent adaptive behavior skills. The result, managing disruptive behavior can improve activity of daily living skills. Next, please. Pharmacological treatment. Next, please. The only two approved is by FDA as for treatment of aggression as antipsychotic is risperidone and Abilify. So, next step. So, the NICE guideline advised us in the 2015 not to start antipsychotic unless the full trial of psychological intervention, social intervention, or other intervention. Then we can add or there is violent behavior, then we can add antipsychotic. The antipsychotic should be combination with psychological and other intervention. Next slide. So this is a very important result in some research. They found pharmacological treatment increased significantly using over the years, from 57% to 64% in 2004. They found very common, unfortunately, in age of 2, and increasing also by the age. And also there is big campaign in UK to stop using the medication they call it stomp and stamp. Okay, next. And also at the end, we have to treat the comorbid condition like aggression, anxiety, ADHD, and also we have to potential benefit and risk must be discussed with the family. Thank you very much.
Very sorry to stop the time, but I think we have already taken a few minutes from prayer and lunch break. It will be difficult to take questions, although most of the presentations needs more discussion. Unfortunately, the opening ceremony had a PowerPoint presentation that was not planned, so that's why we lost around 40-45 minutes from the program. So we apologize for the speakers, but it was very stimulating and interesting talks and topics, and very important. We should have more time to discuss them. Actually, personally, I was having a plan to have more discussion and dialogue, but unfortunately, we lost the time. Thank you very much, Doctora. We'd like to thank all the speakers, the organizers, and I wish you, inshallah, the best outcome of this conference. Thank you all, and you can go for lunch and prayers. Thank you.
السلام عليكم ورحمة الله وبركاته. بالهنا والعافية. تقبل الله منا ومنكم صالح الأعمال. We'll start the first lecture of the afternoon session in 5 minutes. السلام عليكم ورحمة الله وبركاته جميعاً. First, I will introduce myself. أنا صفيناز الحارثي. I'm a pediatric neurologist, director of Developmental and Behavioral Disorders Center in Jeddah. I'll be the moderator for the afternoon session, and we will start our afternoon session with Dr. Amal Al-Hashim, who is a pediatric and genetic consultant. Yes, Doctora, welcome. Yes, she is a pediatric and genetic consultant at Prince Sultan Military City. She also is the head of genetic and metabolic division at Prince Sultan Medical Military City as well. She's the president of the Saudi Society of Medical Genetics, and she is the head of the scientific committee of birth defect registry at Saudi Health Council. She's also a professor at Al Faisal University in Riyadh. She's the president of Saudi Society of Medical Genetics, interested in treatable genetic diseases, and have more than 100 publications. Awarded many awards for the best poster at King Fahd Medical City for Excellence in Medicine. Thank you, Dr. Amal, and we welcome you, and you may start now.
Thank you very much, Dr. Safinaz. Bismillah ar-Rahman ar-Rahim. Good afternoon, ladies and gentlemen. I would like to thank the organizing committee, Dr. Safinaz, for this, and the centers, Marakiz al-Namu, for organizing this prestigious meeting. I'm going to talk about complexity of genetic condition associated with autism spectrum disorder. I know you are coming after, the lunch, so inshallah it will be as delicious as the lunch and as easy to be metabolized and absorbed. So let's see how this is working. Yes. Bismillah. Yeah. Most of you, my lecture will be now in English, and I will, if you need anything that we can explain more, Dr. Safinaz, just inform me. So we'll talk about ASD and how we can genetically diagnose the autism. Is there any genetic factor or genetic cause causing this autism, and you might prevent this in the next pregnancy? So autism are collective conditions that have a common impaired socialization and communication in association with a stereotype behavior. And it is one of the most common and prevalent in neurodevelopmental disorder, and it is, they say that at the recent is 1 in 59 children, and may be caused by either by inherited or de novo. And when I say de novo, means that it is sporadic, it is sudden, subhanallah, طفرة قضاء وقدر, it will not recur again. Up to 10%, in only up to 10% we can find a genetic etiology of this autism. And this is really, really still behind, and we hope we can increase it. And this can be either the 10% can be genetic, or the 90% can be other multifactorial, non-syndromic, and other things. So how we can approach these things? The complexity, I was asked to talk about the complexity. The complexity here, arise because of many factors in the autism. Number one, the genes that we are searching, and all of you would like to see if there is any gene affecting the patient. The genes are multiple. The same gene, you can find it, and the same defect, you can find it in many family members, and they have different or variable expression. The autism itself has heterogeneous or multiple faces we can see with variable expression. And sometimes the same disease, you can find the same genetic change, you can find it, the patient had mild symptoms, and the other side, another patient with the same genetic defect has severe symptoms, and it's the same. So why this one has A and B, they have the same genetic defect, but someone has mild and someone has severe? What is the factor that modified this? And this will also make it a little bit complex. And this is the genetic modifier. We can talk a little bit about it. Before I go, I need to talk to you a little bit about some genetic. دكتورة نورة she talk and خلصت لي شوية, بس يعني التكرار يعلم الشطار. We'll talk about something called variable. هذا كان شغال, ما يشتغل هنا مو مشكلة. Variable expression. You see, this is family pedigree of. أنا هذا صاير شوية أحوس فيه, دقيقة شوية. لا, باك هو في ماوس صح؟ أول واحد اللي فوق صح؟ هو يشتغل هنا بس هنا ما يشتغل, مو مشكلة. طيب, so the variable expression in this family pedigree, you can see number one. Number one is a father who had only the small square down in the right, and this is because of CNS tumor. He had a girl, which is in the second line, number one, and she had also CNS tumor. So she got it from her father. The third line in the left, the first girl, number 3-1, she had optic glioma. She had cutaneous, which is hyperpigmentation in her body. We call it Kaplan spots, and CNS tumor. So she is more than her father, her grandfather, and her mother. She had three things more than them. And then this lady, she gave her birth for her sons, and each one has different presentation. All of them, if you do for them genetic testing, they will have the same neurofibromatosis disorder, the same gene. But the neurofibromatosis can present this and this and this. And this is what we call it variable expression. The other thing, there is several guidelines that we can see what is the problem with autism and how we can solve them. Number one, I will talk about factors suggesting the presence of genetic disease. And this is what you need in your clinic and in your life. If you have a patient with autism, what is the factor that make me think of that this is genetic or this is non-genetic? And the other thing, there are some specific symptoms that show me, oh, this is genetic. And the importance of family history, always ask, and I will show you something about it. Then we'll do counseling and genetic testing. It is complex, but also it is simple. So we will go one by one from simple to the complex. So the first one, this nice girl, you think what she had? She come with mental retardation. She had mental retardation. The mother think that she is very lovely, and actually she's lovely. She looks nice, but she has, if you concentrate, she has the up slanted of the eyes. She had this wide mouth. If you examine her hand, you'll find single semiac creases, and she's a case of what? Down syndrome. So why she has autism? Because of Down syndrome. Of course, the family, they know that she's Down syndrome, but when you come in the clinic and you think that she's fine, mentally retarded, and they are quiet, they don't want to say for you that she's Down syndrome, because it's only autism. And because of some Down, that the feature is a little bit less, so you may mix, this is nice girl, she has autism, and you know that up to 16% of autism, of Down syndrome, they have autism. So how we will investigate this girl as genetic, from genetic point of view, we will do the first basic testing, which is chromosomal analysis, which we call it karyotyping, to check all the number of our karyotype. It is simple, straightforward, and she will have most probably 47 XX plus 21. So the 21, it will be 3 copies instead of 2 copies. And actually that was her chromosome analysis. Now let's make it a little bit more difficult. You have this patient who came with MCA, which means multiple congenital anomaly, and autism. So always the first message I want to give it to you when you think genetic and autism, or there's genetic cause or inherited cause. By the way, inherited not always should be genetic. I mean genetic, sometimes it has happened that this is congenital, sorry. I mean congenital. If it's the patient has congenital thing, it's not always every congenital malformation is genetic. Do you agree? Anyone do not agree? Could be congenital malformation and not inherited, not genetic? Could be, yes. And this is example for the diabetic mother who had baby with malformation. The one who is taking like some medication, teratogenic medication, can cause congenital infection or congenital malformation. So, but if you have a patient who is coming with autism and multiple congenital malformation, think of genetic things there. So we take the history. There is no only congenital heart disease, some of the microcephaly, some other disorders, and autism. There is no family history. We took the basic thing, which is chromosomal analysis, and apparently in this patient, in number 16, you can see chromosome number 16, go one by one till number 16. There is arrow at number 16, and it looks shorter than the other copy. So one of the number 16 is shorter than the other one. And number 16 is important in your patient because they claim number 16 and 15 that many patients may have microdeletion or duplication in one of those two, some of those patients. So by this simple karyotyping, we can get the answer for the patient. You know what is the next step? You want to examine the father and mother and see if one of them, they carry this same or not. If both of them, they don't have it, alhamdulillah, that's fine. So this is de novo, this is new. It happened that during fertilization, it happened that the patient have this microdeletion or small deletion. Now let's go to a little bit more difficult or more complex. At first we say you have a patient, mental retardation, some dysmorphism or without dysmorphism, and autism with some congenital malformation, do chromosomal analysis. And then if it's everything fine, we can go to do another thing. Let's see in this patient. Those patients, I put some photos for them. The patient present with, at age of 9 years, because of delayed development, and he's always happy, and they're doing like this when they walk. They have ataxic gait, so when they walk with help, and they have very minimum speech or no speech. And the parents, as the others, he was fine, and then after 1.5 years, they start regression, and this because of vaccine, كالعادة. معنا دائما تسمعون هذا الشيء. Just because it's most of them, they are diagnosed at that age actually. So he come with severe mental retardation, so he was fine, and then regression. And this is what is painful for the family. There is some regression. He had microcephaly, small head and wide mouth, you can see it. The tongue is sometimes out, and paroxysm of laughter. So just suddenly he will laugh, and no speech. Ataxic, happy appearing, hand flopping, and poor sleep, very poor sleep that the parent always, they are angry because, or they are complaining of poor sleep. So if you are going to, if anyone saw this patient, you say, okay, let's go and do chromosomal analysis. No, here I will not do chromosomal analysis. In this case, the face of the triangular face, the happy, the ataxic, it say that this is not one of the chromosomal problem. You need to do something more specific. Go and do something called CGH array. Dr. Noura talked today about it. CGH array, that we are going to see the chromosomes, but the small deletion, the small thing in the chromosome that cannot be detected in regular chromosome analysis. And when we did the FISH, or something called the chromosomal microarray, in it, this is the way we take normal DNA from normal control and the patient DNA, and they put it together and see if there is any miss or increase. And the patient tend to have one of the microdeletion in chromosome number 15. This is associated with the Angelman syndrome. So Angelman syndrome is a syndrome with mental retardation, no speech, ataxia, and autistic feature. How we can confirm it with this microdeletion, with this CGH, and sometimes it is when they send it to us in the genetic clinic, 70% of Angelman, they will have the deletion. Some of them, they will not have deletion. We need to confirm it by another test. Maybe, and the most important thing you know about the microarray in this slides, not to go more detail. So any microdeletion or duplication that can be seen in the chromosome, the CGH can help you with. Actually, we were discussing with Dr. Zahra, in the West, you know, the guideline, not the guideline, or the practice that any patient with autism, mental retardation, go ahead and do chromosomal microarray. No need to do chromosomal analysis. Step the chromosome analysis, because it is now old-fashioned. يعني خلاص صارت قديمة chromosome analysis. Do microarray. But in our country, in our setting, still chromosome need to be done first for some patients. And the most frequent reported mutation are duplication in chromosome 15 or deletion in chromosome 2 that you can see them by the microarray, not by the chromosome analysis. I'm working with the autism center in military hospital, and we are doing autism clinic per month. So I collect all the patient and some of the patient, and we did chromosomal microarray in our hospital. I am proud that military hospital was one of the first hospitals that implement chromosomal microarray as diagnostic. So, and I collect for you all the number 17, 16, and 15 chromosome and see what they have. Most of them, they have autism. So there is some association. Another thing that I need to tell you about an autism patient, and this is why some patient had gene and affected. And when you test the father and mother, you find that they have the gene, but they are not affected. Okay? They have the gene, they have the defect, but they are not affected. And what is this? This can be explained by something called penetrance. So penetrance means that you see the pink grandfather up. He had the gene, and he had the phenotype. So he had, like, you can say whatever phenotype. He is genetically, he had defect in one gene, and physically, he looks it like this defect, like for autism. He has autism, and he has the gene for the autism. However, his son, which is blue, the second line, he had the gene, but he didn't have autism. So one of his son, we examined him, he had the gene, the same genetic defect in the father, but he didn't have autism. And this son who had no autism was fine. Oh, I don't have autism, so let's get married. He gets married and he have offspring who had autism. So before we call it skip generation, now we call it loss of penetrance. And this is make our life a little bit difficult. How you can explain to the father, you have it, so he had it, why he's not showing it? So this is one of the complexity that we are trying to convince people. This patient had mental retardation, delayed speech, increasing with time, and he had large ears, and when you did chromosome analysis, it's normal. When you did microarray, it's normal. So the most common cause of mental retardation in male is Fragile X, and this is the case of Fragile X. Fragile X is a tricky that it will not be shown by chromosomal or microarray. You need to do test for Fragile X. You need to be clever enough to say, I want to do Fragile X. Or you go to a center that give you a panel for all mental retardation and autism disease and say, I will do for you microarray and Fragile X in one hit. Or genome as genome, that one will do for Fragile X. So this is one kind of disorders. Of course, it's maternal inherited, so it's coming from the mother only. And if the father is affected, he will not give it to the sons or the ladies because he will not give it to his sons because it's Fragile X. It is the X chromosome which is affected. And the father will give his boy Y. He will not give his boy X chromosome. So this is usually coming from the mother, and let's see what we can do for this. Usually, this is the mutations or how many types, what is the severity of Fragile X. It's different according to the test it is done. And I will not duplicate what Dr. Anura talked today. But there are some behavioral symptoms comes with Fragile X. Language delay, autistic behavior, 50 to 60% attention deficit, epilepsy. So really, any patient needs to be, think of it in male, especially in males. So if you have a feature of Down syndrome and mental retardation, this is the most common cause of chromosomal micro problem with mental retardation. And if it's boy, think of a Fragile X. If it's girl, think of Rett syndrome, another syndrome. So now we talk about syndromic, dysmorphic feature, and mental retardation. Let's see if it's similar to some genetic syndrome. Like this patient has atypical facial feature, atypical facial acne. He had facial acne, which is not really black zones or something, and he had seizure disorder, and this is suggestive of tuberous sclerosis. Tuberous sclerosis, you can see it in your clinic. They have seizure, mental retardation, and learning disabilities, and it is important to send for geneticists because they may have rhabdomyoma or tumors. And you can do it by what? By genetic testing. So this is not chromosome, not microarray. This you need to go directly to don't do for tuberous sclerosis chromosome analysis. Don't do it. Just send it to the geneticist. He will do the exam for the genetic testing for TSC. And usually tuberous sclerosis is autosomal dominant. But almost 90% of them de novo. So the first one in the family, he is the first one. No, his father and mother are fine, de novo, but he can transmit it to the sons and the girls as autosomal dominant. 50% of his offspring can have tuberous sclerosis like him. Can we help him? I will show you at the end. So how to test? Chromosomal, I say no. Microarray, no. So we can go to something called the gene. We'll see all his gene, what is it? Or sometimes you don't know, is this tuberous sclerosis or seizure, or he had seizure and he had mental retardation and autism. Can be with many genes. So go and do something called panel. Panel means the lab collect many genes in one chip, in one test. And only this test will examine for you many genes and detect what is the gene of interest for your patient. So, if you open your chromosome, you'll find double-strand DNA. This double-strand DNA, if you open it more, you'll find the exon and intron. And here you will find all your genetic book. You know, this is the ACT, AAT. This is the letters of our genetic or book of our life. And all this will make for you the whole of our difference between us and the others. So this is the Sanger, which I put it. So this is if you want to test like a tuberous sclerosis, sickle cell anemia, whatever, you do the genetic testing. And I thought it is nice to show you how is the mutation, it's fine. And this is one of the commonest diseases in our country. Each 3 nucleotide, each 3 like GTG, CAC, you know, our body is full of those nucleotides, but we don't see them, of course. And each 3, it will give us a codon. And just imagine, what is the difference? Can you check for me? Can you get for me? What is the difference between the first line and the second line, the wild type and the mutation? This one is the normal. G. Let's see. GAG. Oh, sorry. It went there. Yeah. صح. الGAG صارت GTG. Sorry. هذا تغير عندهم شوية. راحت على اليمين. It's the GAG went to GTG and the glutamic acid changed to valine. This small change changed the glutamic acid to valine. What is the problem? The valine is so sticky. If it go and make the RBC so sticky, and it causes the sickle cell anemia. This is the cause of sickle cell anemia with all the problem with a small mutation. So if you want to diagnose something like this, single problem in a gene, do genetic testing. Positive family history, it's important. We have a family, you see 3 affected. His father and mother are cousin, as usual طبعا. وعندهم, the father had ولد عم who is affected also. All of them, they have truncal obesity, they are obese, they are developed later on, they are microcephalic, they are facial feature, it is little bit different than the other, and they have delayed development. And this is the facial feature. You see, they are nice. It's not bad. They are not dysmorphic, but the eyes are close together, small philtrum, and all of them obese and delayed development. And in this stage, you don't do chromosomal analysis in family with 4 or 3 affected. Because if you have like this, father and mother is normal and 3 affected, it is not chromosomal. It's most likely something with gene. And if you want to do the last thing that it will not take from you all the time, go and do whole exome sequence that it will show you all the disorders or all the discs. So how to test this patient? I will not do chromosome analysis. I don't know what is the gene I need to test, so I will do something called whole exome sequence. يلا لو سمحت اطلع. Okay. Whole exome sequence that it will show you all the diseases. Or something called, and when we do it for this patient, we find that this is Cohen syndrome. Did you memorize the shape of those patients? Or لا تبغون أرجع لكم إياها? You have to memorize them. Cohen syndrome is very common in Saudi Arabia, by the way. It is very common. And it is underdiagnosed. It's only underdiagnosed. But Dr. Fawzan Krayi, he managed to collect the most common disorders. And the Cohen syndrome, this gene was one of the commonest, top 20 in our population. But it is underdiagnosed. So please, if you find a patient with autism, facial feature, nice, but it is, round face, small places in between the eyes, and truncal obesity, think of Cohen syndrome, especially if there is family history. This is autosomal recessive, and the risk of recurrence, it is 25% in each pregnancy. And then we'll say how we will prevent this. How we can, I told you a little about the panel, and this is just to show you how panel can help us. And it's available in many hospitals. Like if you are talking, I want to test for autism panel or seizure panel. And there is many, in each chromosome, there is gene, in each chromosome. So I cannot go to the first chromosome, then second, and just do the panel that a small ship will examine all of things for you and will give you the diagnosis. And sometimes it's a little bit also difficult in autism. This is one of the complexity that we call it the somatic mosaicism. This is the explanation why the parents are fine and then they have a patient with autism with genetic problem. The ovum, when it is fertilized with the sperm, it is normal. It's normal ovum, normal fertilized ovum. The zygote is normal. But during the growth, there is some change, and that we call it somatic mutation. Some change that happened after the fertilization. So normal sperm, normal ovum, but after fertilization, the zygote, there's some change, and this is what we call it somatic. This is Rett syndrome. I think you saw it a lot. So Rett syndrome, the girls always
5
doing
minutes,
like this.
Dr.
5 minutes. They are doing like this, mentally retarded, no speech, and this is one of the commonest cause of autism in girls. So boy, Fragile X, when I talk about syndromic. In syndromic, in boys, fragile. In girls, Rett syndrome, and they will present like this, go and do the single gene for Rett. And this is the features for them. They have irritability, seizures come later, and normal development at the beginning. Everything is fine? كويس so far? طيب. Sometimes you need, how we know that the genetic is important even if you didn't have result positive. They study the twin. The monozygotic twin, they find that if one had autism, the other high percentage he will have he will have autism. However, the dizygotic twin, it is lesser percentage. So they say it is something genetic. This family, please don't take photo. عشانها بس أخذناهم للتعليم. This family had 5 kids, all of them. The first one has autism. The other one, all of the others had no speech. The family at the beginning told me there is no family history, and then I find there is 11 family history of similar problem. قالوا لي في الأول ما في أحد, but I find 11 at the end, and we took, the blood was fine, chromosomal, microarray, everything normal. WIS was normal, and then we took him to Dr. Fozan Kraya at Takhassusi, and he did homozygosity mapping, and he found a new gene. He described this gene, ADAT3 gene, and it can cause microcephaly. In some patients can cause autism, one of the commonest autosomal recessive in our country. برضو يعني جايبت لكم كل اللي مهمين جدا. You may see some of them. They have any patient with microcephaly, short stature, squint, think of ADAT3 gene. And what we can do for them, we can do PGD for the family. This is the whole exome sequence that can check for you. The whole exome sequence can check for you 20,000 genes in our body, and it is not the genome. I'm talking about some small part of our exome that can help you to find the disorder. Those genes, sorry, I don't know why this is going up. Those genes are candidate gene for autism, but still, if you find change in them, the patient may have autism, but it's not fully recognized why. So this is, we talk already about them. Multifactorial, there's always multifactorial polygenic disposition in autism disorder, like environmental, and can change the presentation for your patient. Gene with epigenetic modulation are highly involved in autism, and a recent review of 215 genes estimate that 19% is epigenetic, and this is still under, examination. The last thing I want to show you, what happens if you have a patient with autism and syndromic. I'm talking about syndromic autism, autosomal recessive, risk of recurrence 25%. نقول أهل خلاص طلقوا ما تجيبون عيال عشان هذه. No, there is some options that the mother get pregnant, and we will examine the fetus inside her, and we see if the fetus affected or not. If he's affected, after discussion, we can, if it's severe disease, it can be terminated before نفخ الروح. The other thing in the right side, I show you the PGD, pre-implantation genetic gene diagnosis, the way that if there is syndromic thing in the family, the father and mother are affected or carrier, we can choose the normal zygote. We make IVF, and we took this zygote, we examine it. Is it normal or not? If it's normal, we implant in the mother uterus. If it's not, discard. And by this, inshallah, we'll have normal kids. And this is the way of prevention. The new era now, you are listening to her. The mother wants to know if it's Down or not, Down syndrome or not. No need to stick a needle in the mother tummy. This is from the mother blood, can be taken from the mother blood, and we find the free fetal DNA and can be examined for the common Down trisomies, common disorder. Now with the National Guard, I believe they are trying to see if we can diagnose even the small gene from this way. The most important thing, premarital screening. Please, please, please ask about disorders. This family had all these affected, and the mother come to me because she had sisters. Her sister had a sister. Her sister had a daughter. وحتخطبها لولدها. She want to make sure that they don't have the same disorder. I test this son, and he was heterozygous. فكانت خايفة إنه يجي. I test this fiancée الخطيبة وكانت normal. الحمد لله تزوجوا من 6 شهور. فالحمد لله they are fine. But I say it's not the same disorder, but it can be other disorders. عشان in Saudi Arabia, the dual diagnosis that you have 2 or 3 disorder in the same family, it is common, up to 5%. So, بعدين جابت لي الثاني يبغى يتزوج بنت خالته الثانية وطلع كارير. قلت لها تجيب الخطيبة. Bring the, says no, بطلع بعيد العيلة. إن شاء الله شيء كانت صادقة. This is the factors. هذه summary. There is genetic, there is epigenetic, there is environmental, and this is making the complexity. But inshallah, with research, with all together, we are working together. If you are suspecting something, send him to the geneticist, send him, and we have a lot of things, and inshallah we can do it. A lot still to be clarified in the autism spectrum disturbance. It is likely that several susceptibility factors are involved, and some still to be discovered. It's urgent to identify the genetic variant so we can prevent it, and diagnosis criteria have been improved. The ideal diagnosis could be identified in genetic variant for some patient and some phenotype. We can find them, inshallah, and we can help the family. By this, I reach the end. Thank you very much.
Thank you, Dr. Amal. for a very comprehensive talk. You just made the complexities of genetics is
Worse?
easy. No, easy. Thank you so much. And we are now open for questions. Anybody has any questions? تفضلي دكتورة.
شكرا جزيلا دكتورة أمل على comprehensive, really, and very interesting صراحة talk. The only question that I have is, what is your explanation when you have somebody who has a genetic abnormality and has autism, like a child, and you test the parents and they're both normal, and sure enough, the next sibling will have also autism and the same gene. So what's your explanation, and can you elaborate on the germinal line also abnormalities?
Yeah, so thank you for this question. So no, you are asking about a family that they have a patient with autism and you test him and you find a gene. You find a gene and the parents are normal. And this gene is homozygous or heterozygous? I mean, most of time it is heterozygous. So it is coming from one, and he's fine. I mean, the parent having nothing. So if the father and mother has nothing, so de novo, and the patient is affected, and then they got another patient with autism. Now, if you test the other one and he had the same gene, this may explained by germline mosaicism, that either father or mother in their ovary or in their sperm, there is the problem. So if you take blood, it is normal. But if you take biopsy from the sperms, or you take from the ovary, you take biopsy and you see the DNA there, here we may find it. Because as I show you in the somatic, it was that in this father, he was fine, he was normal, and then he had mutation in his sperm, in some of his sperm. So you may take biopsy, but you didn't find anything. It is really, really tricky. And it happened for one with achondroplasia. So he was achondroplasia, he had a baby with achondroplasia, and then how come? And then he get married to another, and then they find it's because of germline mosaicism with him. It is difficult, but we can. It is theoretically, scientifically, yes, but we can try to test it, but not available anywhere. The other explanation, penetrance. If the father or the mother is carrying it and they are fine, it's penetrance, that they have it, but they are not showing it.
Thank you so much, Dr. Amal. Any other question before we move to the next speaker? Thank you so much, Dr. Amal. Thank you. So now it's time to move to our next speaker. And due to time difference, our international speaker, Ms. Mawi Javid, should be the next one. But we have a switch with Dr. Haya Al-Judi, who is a Saudi-raised and US-trained clinical neuropsychologist. She earned a bachelor's degree in psychology from King Saud University and worked as a neuropsychological assistant at major Saudi hospitals. She then earned her doctorate in clinical psychology from Widener University, United States, with a specialty in neuropsychology. Dr. Al-Judi completed a 2-year postdoctoral residency in clinical neuropsychology at Johns Hopkins University Hospital. Under the supervision of world-renowned neuropsychologists, she assists candidates for epilepsy and Parkinson's disease surgery, as well as patients with suspected dementia, neurodevelopmental disorders, or early schizophrenia. She conducted tens of research projects and published in these domains. Dr. Al-Judi commenced her duties as a clinical neuropsychologist at King Faisal Specialist Hospital and Research Center and has been assessing a wide variety of disorders and performing epilepsy and Parkinson's disease pre-surgical evaluations, including WADA tests in both pediatrics and adult populations. Please, let's welcome Dr. Haya Al-Judi to the stage.
Assalamu alaikum. Thank you, Dr. Harthi, for this really kind introduction. Today, I'm kind of going to go over the same topics as Dr. Al-Hashim, except it's between ASD and IQ, so the zoom in is not genetics. Here's my here's my outline for the lecture. First, I'm going to talk about advantages of diagnosing children. Why do we need to worry whether this child has AD, ASD and ID, or ID without ASD? Why do we care about that? Do we dual or triple diagnose? And I'm going to zoom in a little bit on intellectual disability for a change. People have been talking about the autism spectrum a lot, and kind of put the intellectual disability on the back burner. So this could be a refresher for everybody on how to diagnose intellectual disability. And the severity ranges between the type of disabilities and the overlap, which is the actual topic of my lecture today, and prognosis. This is a little refresher on why do we diagnose. Nobody in this room likes to diagnose autism. I think this is one of the least favorite diagnoses ever, just because of the burden and the burden on family and even on the services. But there are advantages, and these are, and the diagnosing has some limitations and disadvantages, but these are the advantages that maybe help you feel stronger every time you have to diagnose ASD. Here they are. I summarized them in P's, so that the acronym is PPPS. The first is parsimony. So this is in Arabic, it means iqtitar. Bita means that things need to be very, very short so they can mean something. For example, if a physician wanted to write a prescription for the pharmacy, they wouldn't want to say the child has fever, runny nose, diarrhea, and list everything. They can just write influenza. So that just made life easier for everybody. So that is one thing. Professional communication, so when you write that down, and for example, if a psychologist refers to a psychiatrist, the psychiatrist doesn't need to redo their own assessment if the diagnosis is already on paper. And the prediction, so it will help you predict the prognosis, and especially with ASD and ID, there are pretty neat things that make us predict the future a little bit with the science that Allah Ta'ala. Fourth, planning a treatment. So again, if you just name the diagnosis, you don't have to go in length in finding the right treatment and program for the person. Everything is available. Number 5 is basically one of the main things that I encourage everybody to remember when they are being a little bit icky about telling a mother that her child has ASD. If you didn't tell the diagnosis that the patient fully met, you might be preventing or depriving your patient from social services and therapy and education that, for example, just made for, provided or created for ASD. And now in this era in Saudi Arabia, things are much better in that regard, not like 10 or 20 years ago in terms of autism programs. So that's that. Parent relief. A lot of parents maybe you came across one who said after the diagnosis of ISD, thank you, you really helped make me, I knew there was something wrong or something off all these years. Now I know what's the problem. Thank you, and now I can move forward. So, and then even in their social groups, social support groups, it's easier for parents if you give a diagnosis for parents to connect. And of course, scientific research and discovery. So yeah, I promised you to talk about how do we diagnose intellectual disability. It's basically these two. IQ test that will determine how the person is able to problem solve, able to learn, judgment and things like that, and adaptive function. A lot of people just do IQ and not do adaptive function. And from this podium, I would say, I encourage everyone, please make sure before you diagnose IED, if you are a psychiatrist, make sure that the adaptive function was done by a trained master's or doctorate level person. Better yet, if they were done in one setting, the IQ and the adaptive by the same well-trained masters or doctorate psychologists, and then have the psychologists have their own report, and then you have your own report. Multidisciplinary is great, but we can't have things on bits and pieces. And you would see that adaptive function in particular is what we refer to when we put the differentiate each type of ID. It is that number. So while IQ is one's ability to learn information and solve problems, adaptive function is the ability of his or her typical level of success meeting every day today demands in society in an age-appropriate way, and at least one of these domains that they would have problems. So for ASD, social function in particular will definitely be down. And a good psychiatric interview also with a parent could get into the information of adaptive functioning. But the referenced tool, norm reference tool done by psychologists is just comparing the person to the average that we have in the for that test. So it's more of a scientific way and quantitative. So these are the classifications of the severity. And believe it or not, this is not the IQ that determined the mild or moderate, severe, or profound. It is the standard score of the adaptive functioning. So that's what, according to DSM, that's how it should be done. It's as if they're saying that the adaptive function is more, you get more information about the quality as opposed to an IQ that there's so many factors that may invalidate the IQ. So in case people were wondering, especially like young career psychologists who would be a bit hesitant to give a diagnosis of ASD on top of intellectual disability. According to the DSM-5 and ICD-10, if the child met both criteria, then both diagnoses are applicable. So just to get that out of the way. All right, so I'm gonna go over some symptoms, maybe 4 or 5. Symptoms say or describe how they are overlapping between ASD and ID, and then conclude, talk a little bit about prognosis and conclude after that. So the first symptom that is, actually when I first was asked to talk about this topic, the first thought that came to my mind was stereotypical behaviors. This area, the two diagnoses do overlap. This what we have in terms of, first I'm gonna describe them, what are stereotypies or stemming. They are behaviors that have no immediate practical significance. There's no purpose, but are performed in a consistent, rigid, and repetitive manner. Movements, examples, movements of the hand, arms or upper body, flap hand, twirl fingers. So hand flapping is like that. Twirling fingers, fidgeting with objects around them, rocking back and forth, facial grimacing, face and head tapping, self-biting, licking, teeth grinding, spinning. All of these could be found in ASD and some ID. We'll see the percentage. What are they? Why are they done? What's the purpose? They're self-reinforcing, pleasurable, could regulate an anxiety or frustration. Repetitive movements that, 1 second, I think I skipped one. Yeah. So they are fairly common in children with intellectual disability without ASD. So if you see it, doesn't mean autism. All right. 71% of youth with both ID and ASD displayed stereotype behaviors. 18 of the higher functions, even if the child was very verbal and has normal school performance and average IQ, 18% of those might have stereotypies. And 31% of the lower functioning children with developmental disabilities. 85 of children with ASD and intellectual disability display echolalia, which is repeating words. So a huge percentage. They're associated with certain genetic disorders. Dr. Al-Hashim, mashallah, covered all of those, seems like it. And now, self-injurious behaviors. They're repetitive movements that can cause damage or harm to self. They could be mild, like skin picking or head drubbing. And they could be severe, like self-scratching, head banging, or eye gouging. For the purpose of attention, that's one reason. They can pick the skin, for example, for the teacher to see. And they could be for self-stimulation. Like a child who puts a pencil in his ear to feel pleasurable sensation. And if you would want to guess which one, which purpose would the SIB in ASD be, you might guess to seek attention or for self-stimulation. So self-stimulation is probably the more common one in ASD-ID. Not sure why this one is not complete. All right, so these behaviors are most commonly found in institutions, people with severe or profound impairments. Basically, the lower the IQ, the more the self-injurious behaviors. And people with autism. Those with intellectual disability and ASD may be 5 times more likely than children with ID alone to show SIBs. The most 2 common ones are head banging and self-biting. Okay, how does IQ look like in ASD? So in the past, up until around 2005, the science or the literature believed that up to 70% of youngsters with ASD have a ID and they meet criteria for low IQ intellectual disability. However, today the percentage is much lower based on a large population-based study. I'll show you that one. In this study, they looked at 18-year-old IQ of 80-year-old children in several centers in the US. 44% of these children with ASD earned IQ score consistent with intellectual disability. So it was 70, and now it's as low as 44. 24% of the children were borderline IQ. 32, which is a pretty big one, had an IQ in the average range or above, so a normal IQ. Girls with ASD were more likely than boys with ASD to have lower scores and have a diagnosis consistent with intellectual disability. Experts don't know why that the percentage was very high and now it's lower of ID in ASD. However, because now in the DSM-5 the spectrum is bigger and the diagnosis even included people who are high function, normal IQ, or high function overall, then the chances of finding people with high IQ are higher. So that could be one reason. In the past, autism was, the classic was not a person with an average IQ or not even testable. Dr. Hashim, mashallah, covered all of those. This is not an exhaustive list, but I'll talk about the IQ a little bit. So indeed, these medical conditions that could have ASD and ID at the same time. In that deletion 22q11.2 deletion syndrome, they might develop autistic-like behaviors when they're young. When they're older, they might have psychiatric and schizophrenic-like, or maybe meet criteria for schizophrenia. The Fragile X also, as was said before, boys more, 25% of them meet criteria for ASD, and the rest appear extremely shy. And in Reds, it's mainly girls, devastating stereotypical behaviors and motor and social skill decline, and then they would have also ID. My next pictures did not load well, seems like it. Haram. Seizures are much more likely among children with ASD and ID, up to 21% or 22%. And then among children with ASD alone. Most of the evidence suggests that in those children, seizures, ASD, and ID are all caused by the neurological problem. However, some people said that it's probably not the cause in some cases. Some cases, the seizures that are what caused the ASD, like having so many seizures, later developing ASD. So they're still researching that. Does IQ affect prognosis in ASD? Can we predict that this person will do well at school, at work, in marriage, or not? Yes, especially for those with a higher IQ. So those with higher IQ, that's a big yes. When they're young, one predictor is if the toddler and infant engage others in play. So they meet criteria, but their play is a bit better. Or if their interest in wide range of play materials was better. If they were showing ability of symbolic play, and if they had more language. These are predictors. In contrast, those with restricted interest or repetitive stereotype behaviors tend to have worse prognosis. About 50% of youth with ASD without a comorbid ID pursue post-high school education or college or anything after high school. About 50%. That's more promising than I thought. So, adaptive function and IQ and ASD, can we predict when we enter those factors, can we predict things better? So adaptive behavior has a atypical development in ASD, and it increases during the childhood and then plateaus, regardless of their IQ. Only 20% of children show improvements in adaptive function over time, while the rest display stable or worsening trajectories. Age, IQ, and ASD, symptom severity, and adaptive behavior have been examined numerous times, but the results are a bit mixed. The link between adaptive skills and ASD symptom severity may be moderated by IQ, so there's some research showing that. and age. But still, it's overall the studies are weak, but it seems like they could be into something here. So in terms of, maybe these are the last few slides. In terms of what are the essential components for neuropsychological exam, for ASD and ID, an interview, behavioral observations, or ADOS, which is the Autism Diagnostic Observational Schedule, IQ/cognitive ability test, language test is essential, measures of adaptive behavior. Adaptive behavior, I can't say enough about it in this lecture. They're not important only because they have components in the DSM, not more عشان DSM قالنا, but they are also help to determine the level of support the child needs at school or at the center. So pretty helpful thing to do. And the rating scales. Conclusions. You can diagnose AD and ASD if the criteria are met. Diagnosis in this population is especially helpful to your patients, so please give them that service if you have enough training and the criteria are clearly met. Never diagnose ID without proper adaptive function assessment or at least a thorough psychiatric interview about adaptive function. This is especially relevant in ASD and ID dual diagnosis cases. IQ is a great predictor for ASD prognosis. There's a good percentage, that's a typo, of ASD caused that have cases that has average IQ. Stereotypical behavior, self-injury behavior, aggression are more common in the dual diagnosis than the single diagnosis. And within IQ scale discrepancy are not great. I was thinking in the past there were some studies that the verbal IQ, if the verbal IQ was better, then it could be Asperger. If it's low, then it's autism. The studies on that is still unclear, inconclusive or weak to say the least, so it shouldn't be used as a diagnostic tool yet. These are my references, and thank you for listening.
Thank you, Dr. Al-Joudi. We're 5 minutes ahead of time. Thank you for presenting such an interesting yet very important and challenging topic. And we're now open for questions to Dr. Al-Joudi. Yes.
السلام عليكم، يعطيك العافية دكتورة. بغيت أسألك، هي بالنسبة للآي كيو والأطفال اللي عندهم توحد، هل تنصحين سبيسيفيك خلينا نقول اللي هو أسسمنت معينة؟
Yeah. So there are tests that people like and they find they are more helpful. In our culture, still we are developing. We don't have as many variety that we can choose from freely than different countries. But we're getting there. What's available, we have a lot. People love Stanford Binet with ASD. They do love that one, and we have that in our country. أيوة. Is not verbal. Yeah. I'm gonna get to that. So ASD. Stanford Binet. I'm not an expert in it, but I know that the nonverbal parts of it are easier than the Wechsler ones. So once you get an idea, maybe you don't get a full verbal, nonverbal, full scale, but at least you get one of the components, maybe the quantitative. But at least you get something from it. It's like the abstract reasoning, problem-solving part.
The thing is إن هو ستانفورد بينه مقسوم بين الverbal والnon-verbal. So مثلا عندك fluid reasoning, quantitative is also you cannot get the full let's say اللي هو أو reflective abilities of the child unless you do both.
Yes.
أحس إنه يظلم الصراحة.
Yes, so you can use the score itself to help you with your assessment. So you don't have to, if you couldn't give the rest, but if you have one score for fluid reasoning, you can speak to IQ. You can say that based on fluid reasoning, I expect that their cognitive ability are this and that. You don't have to get every single score in the scale to use it. You get a standard score, or is it subscale or standard or T-score? One of those, percentile, one of those would work. And people love lighter, 3 in particular. They use it with ASD, but in the books that I've read, they say that you have to say the caveat that it's only non-verbal and you're missing the verbal. If you are able to, my personal recommendation is Wechsler. If you are able to give it completely, that will just give you a full idea. And then those rating scales, adaptive functioning. I can't talk enough about adaptive functioning, and language. And you don't need to give ADOS to every neuropsychological evaluation for ASD. You don't have to do that. Just my recommendation, IQ, adaptive functioning. If you're master's level, well-trained, write your own report, and then it could help the rest of the team. But don't give bits and pieces of your scores. Did I answer everything? I think كان في السؤال كان فيه أجزاء. Yeah, Stanford Binet, because it's validated to our culture. Wechsler, unfortunately, so far not as validated.
Thank you, Dr. Judy, for this fruitful and comprehensive talk. My question is still, there is still different practice regarding the assessment evaluation, and still we are seeing different practice regarding the implementation of ADOS or ADI, whether this is a part of the standard or this will be left for every group will do what they wish, or what do you think?
Right. ADOS is very controversial for some reason. People have a lot of things. It's very helpful. Eventually, the diagnosis, if it's coming from a psychologist and the psychologist is not trained on that, but trained on other methods of, like we need performance-based, we need functional-based informant rating. If you give the child a test and he or she performs well, and then ask the mother information about how she's doing at home, and this goes with this, then you're a qualified clinician, then you don't need that tool. But it is very helpful. But nothing out there says that if you didn't give ADOS, you cannot diagnose ASD.
Thank you. Any other question? Okay, so now we can move to our next speaker. Thank you, Dr. Al-Judi. Our next speaker is Ms. Shahad Al-Khalifa. She is the head of Occupational Therapy Department at Autism Center of Excellence. She is also a consultant, author, researcher, and media commentator offering experience in clinical settings, strategy, and operations to steward best-in-class service delivery. She got her master's degree from University of Brighton and a postgraduate certificate in sensory integration from Ulster University. Let's welcome Ms. Shahad Al-Khalifa to start her talk.
السلام عليكم، مساء الخير جميعا. Thank you, Doctor, for the introduction. I'm glad to be part of this amazing conference, and thank you for المنظمين for everything. Today I will talk about a brief introduction about sensory processing and sensory integration and the co-occurring conditions. Sorry. So our outline for our talk, and we will start about what is sensory processing, coming to causes of sensory processing disorder and the prevalence in Saudi Arabia for this disorder and co-occurring condition, and finally we will end with useful resources for the parents and for the professionals. So to start with, what is sensory processing? So in general, we know that we have 5 senses, but researchers showed that we have 9 senses, which is touch, sight, and smell, hearing, proprioceptions, that mean your sense of body, the grading force, and we have the interoception, that means that sometimes you feel cold, you feel hot, so your sense of the weather, vestibular, which is your balance, and finally for the test. So what is sensory processing disorder? What is sensory processing in general? So it is a neurological process. So it's happened in the brain for finding, integrating, and organizing the sensory information surrounding from the environment and integrated carefully and perfect to integrate usefully in the world. So we have now, for example, we are sitting now in this amazing auditorium. We're listening to my talk. You may listen to the sounds of the cameraman, and you may see the lights, and you integrate all of these kinds of sense surrounding to you, and the brain integrate these sensations, and once it's integrated, these sensations are organized, you respond appropriately. So you again shift your attention to my talk. You focus to the presentation, and you block the surrounding sounds. Additionally, you may change your position on the chair if you are feeling tired. All of this is the process of sensory processing. So what is sensory processing disorder? First, is it disorder? Can we call it disorder? Nowadays, there is, in the ICDL manual, they recognize it as disorder. And also in the DC from 0 to 3 early intervention, they call it as well diagnosis. However, the DSM-5 and ICD-11, they not recognize it as entirely a mental disorder, but it's a feature of ASD and another developmental disorder. So what is the sign and symptoms for this disorder? There is 2 main signs, either hypersensitivity or hyposensitivity. So what does this mean? So hypersensitivity, individuals who are easily stimulated. So that means there is a little bit of any sense, they feel over response. So for example, the input of a light, sounds, and touch. Additionally, these sensations may bother them, so it affects their quality of life. So what is hyposensitivity? A lot feel like a little. So they need a lot of inputs to feel the sensation. And this individual demonstrate absent or reduce of reaction. So they may seem clumsy or they may seem hyperactive. So how sensory processing disorder diagnosed? They're usually done by occupational therapists or neurodevelopmental doctors who can make this diagnosis. The assessment of sensory processing disorder is not easy process. Usually it takes sometimes weeks, many of hours to understand what is the feature for the person who are having sensory. So usually it's done by interview, questionnaire, standardized, non-standardized, checklist, and finally a lot of observation. I'm glad that I was part of validate and translate the one of first Arabic sensory processing disorder questionnaire in our population, which is Saudi Arabia. This questionnaire is basically there is a two questionnaire. One is called مقياس المعالجة الحسية لما قبل المدرسة, which is SPMP, which cover a group for 2 to 5 years old. It's a valid in our culture, and it translated. And we took the copyright from WPS as well. The second one, sorry. The second one, it's مقياس المعالجة الحسية, which is for the older age, from 5 to 12 years old. And it's covered both assessments. It's covered for the home and school environments. So it's measure actually the child integrate of his or her sensory. So we know that the sensory processing disorder affect the activity of daily living. So what kind of activity of daily living? Sorry. Okay. So for example here, one of the activity of daily living, the child should be independent, wearing his t-shirt or her clothes. By having sensory processing, in specifically the touch, may feel uncomfortable of some certain clothing. Also, as part of her daily living, he needs to comb his or her hair, cutting his hair. Due to the sensory processing disorder, he may face difficulty in this kind of activity. Also, not only that, they may grab tightly the utensil or the spoons or the writing, the pencil as well. So it's affect his activity of daily living. Also, they may have dislike teeth brushing. All this kind of activity of daily living, it's affect because of the poor sensory processing. Okay, so we need to understand what are the causes for sensory processing disorder. Unfortunately, until now, it's unknown the causes, but they find several causes could be related or could be causes for the sensory processing disorder. One of them, the premature birth, they found that 46% of children born less than 32 weeks could suffer from sensory processing. Birth complication, so the low weight could also have signs or symptoms of sensory processing disorder. Also, alcohol and drug consumptions during the pregnancy could also genetic factors, and poor sensory stimulation during childhood, which is a lot of screening times, could cause sensory processing disorder. And finally, parental stress also could cause the sensory processing. Unfortunately, the only piece of research that give us the prevalence about sensory processing disorder in our Saudi Arabia, that was done by Dr. Al-Hizan 2015. And in their sample, they found that 88% of the autism have or suffering from sensory processing disorder. And not only that, also in their typical development sample, they also find 32.30%, which is very high. They also have sensory processing disorder. What are the comorbidity of sensory processing disorder? That we know a lot of it. So the famous one is autism. Second one is ADHD, the Down syndrome, epilepsy, and also cerebral palsy. And they found also the people who are having sensory processing disorder, they are 4 times more suffering from anxiety. Not only that, 3 times higher risk of developing external behavior problem, such as the aggressive behaviors. So what are the treatment for this disorder? Occupation therapy can help individuals who's having sensory processing disorder, and not just only the individual, as well as the parents and teacher, to understand how to deal, and they provide a lot of strategies to help them to achieve optimal level and being more independent in their activity of daily living, hoping there to be more effective and engaging in their activities. So the famous approaches that I think all of you know, are sensory integration. They call it sensory integration therapy, SI. So basically this is approach, one of the approaches could be used to treat the sensory processing disorder, but not the only. However, this approach is required specific training, equipment, and tools, and kind of expensive approach to be applied, and to be, even if it's not only to apply, and it needs a lot of time to implement this session, the intervention. For example, it needs to be at least 3 months, 3 times per week, the child receiving the sensory integration. We have SOS feeding, alert program, and their flow time, also different approaches that could be used for sensory processing disorder. Finally, there is a lot of unevidence intervention and studies for this kind of techniques, strategies, intervention, whatever we call, where too limited either show significant or no effective actually for the children, which is the Suzeline. Second one, the middle, the weighted jacket or the weighted blanket. The last one, it's the brushing technique. So these kinds of strategies are not effective, or it doesn't show any significant improvement in the child or the individuals. So to provide some sense of resources, useful resources, there is Arabic lecture, you can scan it. Dr. Sana, she provides a lecture in Center of Autism Excellence. She talked about the sensory processing disorder in very simple language for the parents. I highly encourage everyone to separate this lecture. Second one, we do translate a lot of, in our department, in Occupational Therapy Department at Autism Center of Excellence. And one of the useful article, it's talked about التكامل الحسي للرضع والأطفال الصغار in Arabic. So it's very useful resources as well. Also, we translate the article called المشاكل الحسية واضطراب طيف التوحد. It's as well a useful article. I conducted a case report research for IR sensory integration on a child with autism in Saudi Arabia, and I see the effectiveness of this approach, and what is the recommendation to implement this approach in our culture and population. Also, there is a book resources for the parents. We translated this book, اسمها كتاب التكامل الحسي والطفل, for the parents as well. Sorry, شكله يبغاكم تسوون سكان. No, this one. Okay. And those are books, resources for professionals. I encourage every professional to have those books, are amazing. And it's covered different areas, just not only the sensory integration as well. To sum up our quick talk and introduction, so research studies are necessary to undefine the pattern of sensory processing in our country, in Saudi Arabia. There is a need for more Arabic assessments valid in our culture. It is very important to have availability of occupation therapists, in not just on the hospital, also in the schools, in the community, and the healthcare clinics. Program, we need a lot of programs that's suitable to our culture to educate parents, teachers, and health providers about sensory processing disorder. Finally, examine the effectiveness. We need to examine the effectiveness of sensory integration strategies, and not just only that, all the kind of approaches in our population, Saudi Arabia. And thank you so much.
Thank you, Ms. Shahad, for, yes, a quick topic, but very beneficial and very important. I would like to thank you myself for pointing out on the resources that we can all get a benefit from. And now we can ask Ms. Shahad if we have any questions. Anybody? Yes? No questions? Here?
الله يعطيك العافية. شكرا دكتورة شهد.
الله يعطيك الصحة.
مو مستزعلة كلية الطب بابها. أشكرك على البرزنتيشن. وسؤالي عن يعني صار يبدو في البراكتس وفي الانكونشس عندنا إنه السنسوري بروبلم تحصل مع الأوتيزم فقط. لكن كان يفهم إنه it may occur with other
conditions, yes.
How frequent in other disorders like intellectual disability or ADHD? Is it common?
Yes, for the ADHD, they found around 70% of them, they suffering from sensory processing disorder. Also the Down syndrome as well, the CP, epilepsy. So all of them, they range above of 40% having sensory processing disorder. Yeah.
Thank you very much.
Yes, I always say that the sensory processing is like always with autism. However, it could be with any neurodevelopmental disorders.
Thank you, Ms. Shahad.
You're welcome.
Thank you again.
Thank you so much.
Any other question? Or we can move to our last talk of the day. Khalas?
Thank you. Thank you so much all.
Now we can move to our last speaker from the United States, Ms. Mawj Javed. Is she online? We're almost done. delay. We are having some technical issues. Will be fixed in few seconds. Hi, Mawish, how are you?
I'm good, Safinaz.
Okay, well, this is gonna be our last talk of the day, and I would like to introduce Ms. Mawish Javid, who has a Master of Public Health degree from University of Illinois at Chicago. She's currently is the Program Manager at Children's Healthcare of Atlanta for 3 outpatient large complex multidisciplinary clinics with approximately 10,000 arrived visits annually. She is one of them being the developmental neurology program. Her career is characterized by over 10 years of progressive experience providing program management and program coordination in healthcare and non-profit environments locally and abroad. She is an accomplished healthcare program manager with extensive experience in all aspects of medical services, healthcare administration and training, medical research, service quality, regulatory compliance, process optimization, and performance management. Let's welcome Dr. Ms. Mawish, and you may start your topic now.
Thank you very much, Safinaz, for the introduction. Assalamu alaikum from Atlanta. Good morning from here and good afternoon to all of you. And thank you once again. It is such an honor to be representing Children's Healthcare of Atlanta and Emory University at this prestigious conference. So today the topic that I'll be presenting on is management of multidisciplinary clinic programs. So multidisciplinary clinics grew out of the need to address complicated patients. At best, multidisciplinary clinics provide streamlined expert care from providers who respect each other and work collaboratively. Next slide, please. Thank you. So, what exactly makes a multidisciplinary clinic? It's a shared space, shared appointments, or just a shared cohort of patients about whom communication is a regular part of care. Next slide, please. First and foremost is a vision. Like any other thing, multidisciplinary developmental neurology clinic also has a vision. And this vision is for all the children with disabilities to have early, timely access to the best therapies, resources, and care. All children deserve the best care regardless of income, education, race, and gender. With this vision, I think any multidisciplinary clinic is off to a great start. Next slide, please. Thank you. Now we talk about the mission. So the mission of this kind of a clinic is to improve quality of life for children with neurodevelopmental disabilities and support their families throughout the lifespan by developing models of comprehensive, collaborative care that integrates the highest quality of clinical service. And here you would see that a lot of emphasis is on the improvement of quality of life, not just for children, but for their families as well. In our opinion, when set up and operated correctly, multidisciplinary clinics are extraordinarily beneficial for patients, exciting and intellectually gratifying experience for clinicians as well, and should be the standard of care in academic departments as well. Next slide, please. So let's discuss what is a unique approach for this kind of a clinic. So the unique approach is that we not only have a child neurologist, we have a developmental and behavior pediatrician, which in our case, we have two. One who is part of our Children's Healthcare of Atlanta, and the other that we work closely with CDC. Psychologists, nurse practitioner, genetic counselor, parent partner, and the social worker. So you can see that it is not just a one-man show. There are a lot of components which make this clinic so successful. And depending on the need of the child, after, and the age of the child, after the neurologist and the nurse practitioner, the psychologist, genetic counselor, and the parent partner, when they evaluate a child, that is after which it is determined that, what is the diagnosis and what the treatment for this child needs to be. Next slide, please. So the management of a neurodevelopmental clinic is very unique. And research and studies have proven that when set up and operated correctly, the multidisciplinary clinics are extraordinarily beneficial for patients, exciting and intellectually gratifying experience for clinicians as well. Now, these appointments, as you can see, are very complex for complex patients, and they are pretty long appointments. So they can last from an hour to 3 hours, depending on the specific need of the healthcare needs of the child and how many providers he or she is needing to see. A comprehensive feedback to discuss a child's diagnosis, their strengths and weaknesses, and recommendations for a medical or a neurological testing are some of the interventions that are, which are the result of this clinic. Next, please. So again, after a child is diagnosed, we just don't leave it there. We provide different kind of resources for the parents, because as I said, this is something, the core for this clinic is to not only make, to make sure that these children are treated well, but that their parents are also provided with the necessary resources to make their lives easier and to make this particular child successful in their school, in their careers, and having a lifelong wonderful experience. And we understand that having a child diagnosed with a neurological condition can be an emotional and overwhelming experience. For any multidisciplinary program, the top priority should be supporting children and families. Thus, the intent is to support the family while their child is in their care and after they leave for home. Some of the things that we particularly do for the children or for the patients in our clinic are we provide them for camps or provide them for resources for camps for special needs children, family support services, parent partners, hospital amenities and services are provided and are available for these children. And again, the programs are the special programs that are also offered by Department of Health. In our case in Georgia, there's a specific program called Parent to Parent. They provide resources for the children, helping them in school and helping them even once they are adults. So, helping them with the transition as well. Next slide, please. Now, talking about transition care to adulthood, this is again a very important component of a multidisciplinary clinic. So it's not that when the child is of a certain age, he's treated, but when a child is 14, it is time that we begin talking with the patients to involve their pediatrician and specialists about a transition plan to ensure a smooth and timely process where this child then is able to be independent, and whether they have to go to college or a technical college or do anything in life, so that they are successful and they become an important component of this society, and this transition is easy for them. Some of the resources that we have available in our state of Georgia are Georgia State University Center for Leadership Disability, Georgia Advocate Office, and Georgia Council of Developmental Disabilities. And I'm sure wherever this kind of clinic is set up, it's important and it's imperative that these kind of resources are sought out for these children so that the transition to adult care is easy for them. Next slide, please. Now, again, what are some of the advantages of this kind of a clinic? I think the most important advantage that we have seen and research has proved is that the convenience for patients traveling from a long distance. If I give an example of our DNP clinic in Atlanta, which is a metropolis, but much of the surrounding region has limited or no access to specialty care. Patients from all around Georgia come to our clinic. Sometimes they have to travel 2 to 3 hours just to see our physicians. And for such patients, it's a tremendous advantage to see numerous specialists in one visit. It's a one-stop shop for them. And many rural areas lack access to pediatric neurologists. The second most important advantage is the early identification and screening of children with developmental delays. Any neurologist, any developmental and neurodevelopmental pediatrician or a neurologist would agree with this, that regardless of the type of severity of delay, evidence demonstrates that all children who have developmental delays or disabilities definitely benefit from early recognition of the problem and timely treatment. And this kind of a clinic provides that to that child. The next and the most important or a major advantage of this kind of a clinic is access to other specialists who understand neurological condition. These specialists trust each other's assessment and can directly coordinate urgent care without the need for the cumbersome referral processes. Communication is, again, a really important component. So with providers outside one's institution and often even within the same institution, it has seen that it is difficult and insufficient to communicate with each other. But in this case, everybody is present at the same table. They can discuss this child openly, freely, and with the personal relationships and are created by working together in this multidisciplinary clinic. And these are some of the key establishing open lines of communication. And last but not the least, the educational opportunities are amplified. We have residents, we have fellows who are part of this whole clinic, and they learn how the child is treated in this kind of an environment. And the ability to learn from diverse specialists make a multidisciplinary clinic favorites among fellows and residents. So it's such a great environment to learn for these doctors as well. Next slide, please. Again, anything that is done at this level, it also poses challenges. But again, there are solutions to these challenges as well. And I won't say that everything is very smooth. Day to day, we also find some things that are, that just happen and they need to be treated or they need to be rectified, those problems. And I guess program managers like myself are always there to help out our physicians who are, doing a wonderful job treating the patients there. So one of the things that the multidisciplinary clinics require is more time and care coordination. So if any institution is thinking of developing this kind of a model in their healthcare system, they have to see that this requires more time, care coordination. Other considerations is that time is saved. But you have to also consider that time is saved when coordinating care directly with someone, respective to the patient's needs, is quickly and sufficiently offer their perspective. The scheduling gymnastics of trying to fit one patient into a clinic with two different providers is also not easy. But again, our support staff is absolutely wonderful, and they help us accomplish all this in one day. Ultimately, time up front to train support staff and schedule patients is rewarded when more streamlined appointments and testing is done. The next thing is availability of providers with necessary expertise. It's not always, not every institute has the necessary experts at the same table at the same time and access to each and every provider. However, we have found that early career faculty members are often more interested in developing a new system for themselves, and this is good for their career advancements. To achieve expertise, a person must first have an interest and then gain experience. So I think it's very important that we find a team which is dedicated and which really wants to lead with this kind of a system or this kind of a clinic. Another thing is that limited physical shared space. Sometimes clinics do not have. We are fortunate that Children's Healthcare of Atlanta has the facility and that patients can be treated in this kind of a clinic. But it is unrealistic to have all specialties in the same clinical space. And research has proven that sometimes this can be done over different clinics as well. So this is one thing that can be done. But again, close communication is really important. Phone calls and messages in clinics where one provider coordinates care that takes most messages, but when multiple providers are caring for one patient, who answers these messages? However, our clinic uses a message pool, so the providers have access to these shared in baskets, and whoever sees that, and if it's directed to a certain provider, they would go ahead and they would answer these questions directly. So again, just to say that this is a smooth process, but again, at the same time, needs a lot of planning and a lot of executive decisions that need to be made before we make this clinic successful. I will end my presentation today by stating that as part of a nationally recognized child neurology division, we aim to become the premier destination for complex neurological assessment and medical care in the nation and worldwide. Our comprehensive interdisciplinary program integrates the highest quality clinical services, families through the childhood disabilities journey, train the next generation of compassionate providers, and accomplish purposeful research and quality improvement. And I'm so glad that I'm part of this great and wonderful team. Thank you so much for this opportunities. My address is here and my contact information for any questions or comments. Please reach out to me. And thank you, Safinaz, for the time.
Thank you, Ms. Javid, for a very intensive talk. As we all know, thank you for sharing your experience in management. As we all know that our field would definitely need a multidisciplinary approach, this was very helpful. Thank you for participating again in our conference, and we can now have any questions to Ms. Javid. Anybody has any questions? Khalas. Well, I would like to thank you again for participating with us, and I wish you have a great day, as it's early morning in Atlanta, right? Thank you.
It is.
Thank you, Mawish.
Thank you very much, Safinas. Thank you very much.
Thank you, bye.
Assalamu alaikum.
Wa alaikum assalam. This was our last talk for the day. I would like to thank the attendees. Thank you so much. And I wish you have a great day ahead. We'll see you tomorrow, inshallah, بإذن الله. يعطيكم العافية. شكرا لكم. Thank you, cameraman.